I invite the first speaker. Over to you, sir.
After the lovely evening, thanks to Jatin and everybody's input, we welcome you on day 2 of the symposia. I'm sure that the youngsters are just joining in fast and they're going to benefit from this session immensely. So, can I invite Dr. Jatin Talwar for the first talk?
Recording in progress.
Hi, good morning. We always wonder why they keep on saying recording in progress. Yeah. She has warned us quite a lot, huh? So, guys, I can see that the attendance after yesterday's bash, and I must tell you, it's really great to be on the stage again in a different form, other than yesterday. So, this talk is more often used for the younger crowd and my younger colleagues. And I would tell you that yes, templating is one of the most important aspect of total hip replacement because you actually already know the difficulties which you will encounter during your surgeries, the implant sizes which you're going to have probably at least within 90% of the times. So, what are the reasons why we want to template your hips? So first of all, it is quite accurate in implant sizing, and moreover, the best possible thing is that your inventory management. Sometimes we are not aware of the implants we are going to use for the surgery, and at the last moment, that implant is not available. And the law of Murphy's is the size which you want is actually missing from the stock. So we don't want to land up into such situations. And unusual anatomic considerations. I must tell you that Indian hips are not the same as Western hips. What we read in Western literature, our Indian hips are absolutely different. The most common example is our necks are more towards the varus side rather than the valgus side. You'll most commonly find that you're getting the size of high offset 127 degree stems. And dysplastic acetabulum, you always see that childhood problems, childhood disease, dysplasia of the acetabulum. Your acetabulum is not of the same orientation as what it should be, as what it is written in the books. And femoral bowing, I must really warn you about this condition. Most of us are used to seeing AP X-rays of the hips while templating and during clinical visits. But you won't be surprised that your femur is entirely bowed. And when you try to even put a uncemented regular length stem, it becomes a real problem. And we have all seen that in cemented hips, you just perforate the cortex. We are not aware of the femoral bowing. You perforate the cortex, and the whole cement is coming out of the canal post-op. Very embarrassing. So we are also anticipating the position of the cup. Very important because we want to restore the anatomical center of the hip. We want to know that at what angle and at what level you should cut your neck. And of course, three most important things which you see in the last thing is that you have to restore the hip center, the anatomical hip center, and you have to restore the leg length, and you have to, of course, restore the femoral offset. If you are getting these three things right, then you are definitely doing a good hip. And all of us know that what is a vertical drop, what is a neck length, and what is the offset, horizontal offset, vertical offset. So this is a landmark article which was written by Edgley in JBJS 1998. So according to this article, if you template your hips properly, it is in 90% agreement with the cup size, 92% agreement with the stem size. That means at the most there is a chance of getting one size up or down. And if you see the center of rotation of the hip, that's a very, very less difference if you template your hip properly. 2.5 millimeter plus minus 1.1 millimeters on vertical offset. So that is quite an accurate center of the hip. You are templating hips properly. For the horizontal, it's 4.4. And the mean limb length discrepancy, 3 plus minus. So that's all the data from the article. And if you see more than 80% of intraoperative difficulties, you can already anticipate preoperatively. So if you are going planned, then you are definitely not failing in your procedure. बहुत बड़े बड़े लोगों ने they have said this thing quite a lot. If you fail to plan, then definitely you are heading for a failure. Why do you want to restore the anatomical center of the hip? If you see in the first image, that's the anatomical center. If the anatomical center is placed right, then the tension in the capsule, the tension in the glutei, the adductors, everything is perfectly fine to stabilize and balance your hip. Whereas if you are making your hip center proximal, or if you are putting your stem further down into the femur, you are laxing your hip and your hip won't be as stable as you want. Very important consideration, you should have a good quality radiograph first, which is taken at this criteria 120 centimeters the tube, and it should be absolutely perpendicular to the pubic symphysis. So what would be the radiograph? AP pelvis. It is properly centered, and you should be very, very careful of lumbar hypolordosis. We have the recent concepts of pelvic tilt, sacral slope. That is very important to justify your anteversion of the cup, because you have to adjust your anteversions intraoperatively as well. That is dynamic balance of a hip. And then flexion contraction of the hip. So that is your AP, a good quality AP X-ray. And what are the precautions? If you see neutral, it should be neutral rotation. How do you see neutral rotation? You should see both obturator foramens in the same shape. They should not be winking or cat eyes. Dr. Ranawat had described beautifully the obturator foramen appearance. And the both ileum should be of the same profile. If one ileum is narrow, the other is broad, that means you are definitely looking at a rotated pelvis, right? That is exactly what you do in Jude's view of the pelvis. So there should be a normal AP view, and it should be neutral pelvic tilt. By pelvic tilt, I mean what I just meant. So sacrococcygeal pubic distance, in males it's around 3.2 centimeters, in female more than that because of the wider pelvis. And tip of the coccyx should be approximately 1 to 3 centimeter in males. So these are the AP landmarks, which this slide comes again and again in all the talks of hip and acetabulum. So you just remember the posterior wall shadow, anterior wall shadow, iliopectineal line, ilioischial line, acetabular tear. I'll talk about the chorus teardrop later on, and the dome, the sorsal. So these are the lines, and that's your teardrop, the red one, and that's your dome of the acetabulum. So that is when you want to measure the pelvic height. So first of all, the height of the pelvis is measured by the highest point on the iliac crest and down on the ischial tuberosity, two parallel lines, and then you join these. The line in the center, do we have a marker? The pointer. And the line in the center is the inter-teardrop line. That is also a very, very important line to make. So how do you template the hip? First of all, very important to visualize the teardrop. Teardrop is nothing but a radiological projection. It is not anatomical. You don't see it intraoperatively. You just see it on the radiographic projections. The second is the ilioischial line, which is running right here. The second line, that is the ilioischial line. And then 3, which is the acetabulum saucer, the eyebrow sign. So these three are very important things. And that is right, you see that is a teardrop if you mark it. I'll just tell you how to mark. So if you see this is formed by the ilioischial line in one projection. That's an experimental thing, and the X-ray taken of the sawbone. That's the ilioischial one. And then you have the lateral wall, which is formed by the floor of the acetabulum. And then down there you have the shadow of the acetabular notch. So when we combine these three borders, you get that teardrop. That red thing is very important if you want to template hips properly. On AP pelvis, you see the femoral geometry. You see if there is any evidence of narrow isthmus. You just mark your femoral neck offset. You see your neck shaft angles. And on lateral hip, as I was telling you, anatomical consideration, femoral bowing. That's a straight stem going down this board. A femur is going to create problem. We go stepwise. Get correct templates and magnification. Most of the templates are at 120 degree, 120%, that is 20% magnification. And most of your X-rays which you get, the digital X-ray these days, you should always order 20%. But be aware, because the radiographer or a radiologist is going to write down, sometimes it is written 10%, and you are doing it with the standard templates of 20%. Be very careful. You have to determine the leg length, the cup position, the femoral component, neck cut, everything. So see, these are the different templates available with different brands. And if you notice, this is 2 different types of femoral stems are available here, 132, 127, which is again in this also you have 2 different available. So you have to template your neck shaft angles properly. And how to determine magnification? Just the textbook teaching by the coin, and then you see how much magnification. Yes, this is what I was telling about. Just beware, right here it is written 10% magnification. So if I template my 20% magnification, that I will have an error. So measuring the leg length, if you want to measure the leg length, yes, this is how you do. That is one line joining, and that is an inter-teardrop line, and then that is the upper border of the lesser trochanter on both the sides, and then you measure the length. So I think the time is just needed. So that is how you place your acetabulum. If you see the acetabulum is quite short here, it is not even filling your acetabulum. And this is the superior, that is the eyebrow sign I was telling you, this is right here. So this is a small acetabulum. This is never to be done. Whereas this is a well-fitting acetabular. It is just, there is some posterior superior overhang of the cup, the center of the hip right here, inter-teardrop line. And then you go ahead with this, that's the angle of the inclination. And then that is a placement of your, presumptive placement of a cup in the center of the hip. That is upper border of LT. From here you can also measure the leg length. Femoral component, again, you have to see following things. The stem has to fill the canal properly. It is along the long axis of femur, neck shaft angles, correct size of neck cut. And you have to measure the placement of stem, tip of the greater trochanter and then shoulder of the stem. Because that is what you see right intraoperatively. You have to measure that on pre-op. Please don't forget to do it. And that is a femoral offset. Of course, I've talked about it. And see, that is a stem which is not filling the canal properly, whereas this stem is filling the canal properly. Then you mark the centers of the, that is, yeah, I'll just take a minute more. That is the center of the femoral head, and that is a measurement of the shortening neck cut, and that is the red line is a measurement of your shoulder tip distance. So then these are the few case examples, how you measure them. And then you measure the planned reduction, how much shortening you're able to correct. Medial osteophyte, always remember to place your cup properly. Please don't template it like this. You don't place the cups on the osteophyte. You place the cups in the acetabular floor, right? So be very careful about these. So that's the right placement. Again, a good template is going to bail you out of situation like this. And that is the Ranawat message of acetabular sizing when both of hips are involved. One line, two line again, and that is a Shanaton's arch. And then you draw the iliaceal line, and then you draw a point at the 5 millimeter lateral to the intersection of these lines. And from this point, you drop a vertical perpendicular, measure 1/5 height of this distance. And then from 1/5 height, you draw 1/5 height right from the teardrop vertical, one more line perpendicular, and then you join these two lines. So the dotted line is going to give you the size and the diameter of the acetabular. These are just the case example, nothing specific what I just told you. And I just borrowed these trauma CAD slides from Dr. Ramnik, as we are not doing them regularly, and also the MACO ones. So just a quick recap of these. So that is a trauma CAD. Trauma CAD is a digital software which automatically gives you the type of stem, type of acetabular cups, and that automatically gives you the calculation of your leg length and everything, the offset. And so this is how you get the report of trauma CAD. And that is just a small video of the MACO, where you get your preoperative CT and then CT defined, you get the images on the advantage is that you get the neck cut, you get the floor of the acetabulum, everything right there on the software, how much you're correcting, how much you've already corrected. But of course it needs a lot of equipment thing and the practice. So that is how you see the acetabulum and all. So yeah. So in summary, you have to preoperative template. It is very helpful. It improves your accuracy, precision. It is a very stepwise and systematic approach. And you have to ensure radiographic reliability and of course for good preoperative templating and planning. Thank you very much for your attention.
Thank you, Dr. Jatin.
Yeah.
I think that was extremely well shown. I think
Thank
the
you, sir.
junior colleagues would really benefit. I'll invite Dr. Deepak Raina for the next talk. He'll be talking about optimizing limb length.
Good morning all. So basically optimizing limb length, we are trying to actually correct any limb length discrepancy which existed preoperatively. And trying to get the two limbs correct. If you see the incidents, they are reported from more than 25% up to 50% limb length discrepancies are reported post-operatively. And a third of patients with a limb length discrepancy of more than 1 centimeter are symptomatic. Lengthening is less tolerated as compared to shortening. Even 0.6 centimeters of lengthening, the patients may be complaining. Categorized into more mild, moderate, and severe, less than 1 centimeters, 1 to 2 centimeters, and more than 2 centimeters. So if we see the preoperatively, there are risk factors, whereas there'll be a short limb. The anatomical shortening would be because of osteoarthritis, avascular necrosis, post-traumatic deformities, fractured neck femur, malunion of the neck femur, non-union of the neck femur, sometimes the varus positioning, and various other deformities. While as a limb length in excess would be because of a coxa vara setting. Depending on the type of femoral geometry, the drawer A or drawer C type, There are chances that they may end up with a limb length discrepancy. In a drawer A, they may end up with shortening because we tend to use a smaller size stem with a lesser offset. But they may also lead to a lengthening, particularly in uncemented hips, where we just cannot put in a proper size stem and it stays proud. In drawer C, the probability of the stem going deep will cause a shortening in the long run, and if we put a bigger size implant, it has a bigger offset, may cause lengthening primarily. There are some extra articular risk factors involved, like pediatric trauma, which has led to an increase in the length. There might be a malunion or a non-union or a shortening in tibia or femur. There might be genovalgum or varum leading to limb length discrepancy. And there are some functional risk factors wherein we have to assess that it's a functional lengthening. There might be some marginal osteophytes causing adduction deformity and presenting as shortening. There might be a fixed pelvic obliquity. So intraoperatively, what are the causes? Intraoperatively is what we can control and what we should look into. Sometimes we put our center of rotation downwards and laterally. We do not seat the stem properly, and it's difficult to obtain a stable reduction. Sometimes the tissues feel lax, particularly when we are dealing with an elderly neck femur fracture. The tissues feel lax, we are not used to that laxity, and we tend to pull them down and increase the length. And sometimes we really are overzealous about reaming the acetabulum and accept a high acetabular center. Okay, so we see some examples like the medial osteophyte Dr. Jatin just said, talked about. If we don't deal with this medial osteophyte, we'll end up in a high center and probably a shorter limb. We have to try and compensate it with a longer femur then, but that's not the right way to do things. A better way would have been to template it, get our acetabulum in the correct position and get the limb lengths correct. Similarly, if we don't understand where our teardrop is and where our beginning point for the acetabulum is, we have not templated it, we may end up in a very, very high acetabular placement, leading to a definite shortening, which is not compensated by a long femur which has been put. So superior migration, center of rotation is too deep, rimming is excessive, and sometimes excessively deepening the stem, particularly in drawer type C stems. When we are trying to put in the first fit stem, they just sink in and may cause shortening. You see in a valgoid limb, we have put a short, very short stem and it's sunk in. Patients will not be happy. And is the limb lengthening inequalities based on surgical techniques? There was a prospective study done, but they found no discrepancy in anterior or posterior approaches. The limb length discrepancies remained the same post-operatively. And cemented and uncemented stems, there is a huge difference. In uncemented stems, significantly reduced limb length discrepancies, because peroperatively you can control the depth to which you can put the cemented stem. You can control the offset, while as in uncemented stems, it's very difficult. If you get a press fit, you just cannot push it further. It will cause a fracture. So there was a significant increase. So almost 50% of the patients with uncemented hips had limb length discrepancies more than 5 millimeters, which was significant. And what if there is a post-operative limb length discrepancy? What happens? A lot of issues. Balance may be altered. The patient doesn't feel normal about it. Long run, they may have gait disturbances, back pain, generalized hip pain, sciatic nerve palsies if it's extremely lengthened, ipsilateral knee pains, long-term loosening. They will need a lift on the same side or the opposite side, and ultimately might require a revision surgery as well. If we see about the nerve, causing a sciatic nerve pain, so around 1 inch lengthening will cause some symptoms of sciatic nerve. If it's almost 2 inches, then definite sciatic nerve palsy. People have had poor scores outcome. The walking, the gait methods have been poor post limb length discrepancy. And what are the methods and techniques to overcome it? Preoperative templating, as we have just learned, is an excellent way of doing it. Intraoperative measurements with some markers and references, and then we can have the technology into it. So preoperating templating, various papers are there. So up to 60% has been found to be good in, but we just cannot rely on preoperative templating because there are certain cases where there will be a mismatch, there will be an error on the by the radiographer or by the person doing it, and most of the times we will not find templates. The company will not provide you templates. It's hard to catch hold of them and get the templates to you. We have learned about templating. So intraoperative techniques, basically we need a fixed point on the pelvis and a fixed point on the femur. And we need to measure them preoperatively, knowing the preoperative limb length discrepancy. And post-operatively, once we have finished, once we have put the trial components, we measure the lengths again and see whether we have compensated for the limb length discrepancy, the same points. So there are various methods which are used both to measure the vertical as well as the horizontal offset. Intraoperative techniques would be a caliper method, wherein a caliper is used to measure both the depth, both the vertical as well as the horizontal offset, has been found to be pretty reproducible, difficult to catch hold of. Then there is a thread technique. Again, we put a thread to a pin and measure a landmark which is marked on the greater tuberosity with a cautery, and you measure it before you dislocate the hip and then after you dislocate. The Ranawat's technique is putting a Steinman pin in the infraquartiloid fossa. I have found it very difficult to do it because to retain the pin there while doing the femoral side is almost impossible. And then if you remove the pin, then to find the hole again is not at all a wise idea. I have not found it practical. There are some skin suturing techniques where a suture is put in the skin and measurements are done by that. Some stalwarts here are doing it, again very unreliable. What we do in certain cases is measure with a K-wire on the supraacetabular pin that is used to retract the gluteus medius, so in the posterior approach. That pin can be retained throughout the surgery, and we can measure both the horizontal and the vertical offsets. The limitation is that you have to place the limb in exactly the same position before dislocating, and once you are templating, once you are measuring with the trial implants. Okay, so in bilateral hips, it's pretty easy. You can lengthen one side, and then you have to just compensate and do the same thing on the other side. You know the sizes, templating is already done for you, but it's not always that simple. In certain cases, if you just reproduce the implant geometry, they may have different femurs, both side femurs will have different geometry, and you may sink in the stem more and cause a limb length discrepancy, which is an embarrassment. So how do you manage patients with limb length discrepancies? If it's less than 1 centimeter, probably physical therapy, strengthening their abductors, a shoe raise if required, some minor procedures like change of the head if it's possible can be done. More than 1 centimeters definitely might require change of head. If it's possible, you put in a minus head and you can go for a plus head. Femoral or acetabular component change is a radical surgery, but sometimes in younger patients and high demanding patients, you may have to go for that. More than 2 centimeters of limb length discrepancy component change is advised, and a revision may be required. In elderly patients, even with 2 centimeters discrepancy, if they are not complaining of pain, you may just give a shoe raise. So to summarize, limb length inequality is quite a possibility even with whatever you do, and you should take good pre-operative measurements and try to develop a technique of your own to measure intraoperative lengths to correct the limb length discrepancy. So you template, you use your technique, and you use technology in the form of navigation or robotic. A simple technology, a C-arm shoot peroperatively, one should not hesitate in taking that if you are not sure about the positioning of your components. If it's hip stability versus limb length, I will prefer hip stability because the patient has been counseled preoperatively that hip stability is what I will look at and not the components. Particularly if you are dealing with uncemented implants, the patient has to be counseled well. If post-operatively the patient still complains, you assess the patient thoroughly. You accept that there is a mistake and act if you need to. Thank you.
Thank you, Deepak. I think both these topics were extremely important for all our colleagues. Deepak, please join on the dais, please. Both these topics were extremely important for all colleagues, especially our starting younger colleagues. And each time in every conference this is discussed, but it probably is not used so often. So the more difficult topic now is being dealt by Dr. Mahesh on the spinopelvic concept. Mahesh, please.
Yeah. Thank you very much and good morning, everyone. It's always difficult to kickstart the day. And I think the first session is always going to be a tricky one. But I think this topic is important. And it's fortunate that you are also going to witness the surgery immediately after this using the robotic technology. Now, if you see what are the causes of revision total hip replacement, instability is probably a leading cause, as you can see, followed by aseptic loosening and other causes. And if you see the registry data as well as the paper from Bozic et al., that is proven. Now, we all have been chasing the Levenick safe zone. We all understand the inclination of 40 plus or minus 10 or antiversion of 15 plus or minus 10 has been a standard in our practice for the past 30, 35 years since Levenick originally published his paper. If you read that paper, you can see that unfortunately it was quite a primitive paper and it was just a case series and it did not really, they even had dislocations in the safe zone themselves. In the last few years, you started wondering whether this Levenick safe zone is really safe. And if you see this article by Larry Dorr about death of Levenick safe zone, and that is because of the evolving concepts and the papers that were being published in the past decade. If you see this study from Hospital for Special Surgery, 7,000 total hip replacements, and there was no difference in acetabular component. Whether they were in the safe zone or they were not in the safe zone, they equally dislocated. So another paper from Mayo Clinic, so big papers from Mayo Clinic and HSS have shown that the rate of dislocation doesn't depend on whether you put the cup in the safe zone or not. So I think that is where the death of Levenick safe zone concept has started picking up. So why do these hips then dislocate? If you're putting them in the right position according to the norm which is being set in, so why are these hips dislocating? Maybe we are ignorant of the spinopelvic relationship. Increasing papers started coming in whether there was presence or absence of sagittal spinal deformity in these patients. And then we started chasing and understanding whether there was any spinopelvic imbalance in these patients. And for majority of total hip replacement patients, if you see 6% of the population who underwent a hip replacement usually ends up having a stiff spine. And it doesn't necessarily mean that they've had a surgery. So even if they've had no spinal surgery, they might still have a stiff spine, and you need to look at it properly to make a decision intraoperatively for cup change of anteversion and inclination. So you need to understand only three parameters. One is the pelvic incidence. So what we do is center of the hip joint is drawn, and if you don't have a concentric lateral X-ray of a center of the hip joint, you need to take the average of the two femoral heads, and then you connect it to the sacral promontory with a line from the upper surface of S1. So you draw the upper, this line, this is not very good, the pointer, but anyway. So the pelvic incidence is calculated, then the second thing you calculate is the sacral slope. So it is the upper surface of S1, and you compare it with the horizontal. So you draw a horizontal line and upper surface of S1. Can you see it? It's very faint. So this is the sacral slope. This is the pelvic incidence, as you can see, this angle here. And the third is the lumbar lordosis, top of L1, top of S1, and you calculate the lumbar lordosis angle. So once you have this information, what you need to understand is there is a change of pelvis from a standing to seated position. In a normal patient, when you are standing up, you have lumbar lordosis and the pelvis is tilted slightly anteriorly. As you start seating, when you start sitting down, the lumbar lordosis is obliterated, the spine becomes flat, and the pelvis actually turns anteriorly. And that's why you get more cover of the hip joint posteriorly, and the hip dislocation in the posterior aspect is prevented. And by tilting the pelvis posteriorly, body has very cleverly also accommodated the femur, which comes and impinges with the thigh. So I think that is a normal process from standing to sitting. So what happens in certain patients? So in all patients now, in our practice, we get a standing X-ray and a sitting X-ray of the lateral lumbar spine. So, and then you calculate these two angles. You calculate the pelvic tilt and the pelvic incidence, and you also calculate the sacral slope. And you need to change, see what is the change in sacral slope and what is the pelvic incidence which changes as well. So we will talk about it. It's not a very difficult concept, just a new terminology which is a problem. So two things need to be checked when you have to classify. One is whether the patient has a stiff spine and whether he has a flexible spine as well. So spinopelvic balance and spinopelvic motion are the two things you need to check in. So how do you check spinopelvic balance? So you calculate the pelvic incidence, you calculate the lumbar lordosis, and you subtract the lumbar lordosis from the pelvic incidence. And then I will tell you how do we judge whether the spine is balanced or unbalanced. And spinopelvic motion, you calculate the sacral slope in standing position, you calculate the sacral slope in sitting position, and you find out the delta of standing minus sitting. And those two things are important. So that will tell you about the spinal stiffness. So you understand about the spine, whether it is balanced, and the second thing you understand whether the spine is stiff or not. So this is the paper which started people getting into thinking about it. The group from HSS, Dr. Vigdorchik, then came up with his classification for the stiff spine. So first thing is you need to calculate the pelvic incidence minus lumbar lordosis. And if that is less than 10, you have a balanced spine. If it is more than 10, it is an unbalanced spine. And in both those cases, you add the sacral slope. If the sacral slope is more than 10, you have normal mobility. So you have normal balance, normal mobility. This is a normal patient. In the type 1B, you have a normal balance, but you have a stiff spine. And similarly, in the sagittal spinal deformity, you can either have unbalanced spine with normal mobility or with a stiff spine. So quickly, we will go through examples. So type 1A is a normal patient. The spine is balanced and the hip, it is also flexible. In these cases, the sacral slope changes more than 10 and the pelvic incidence minus lumbar lordosis is normal as well. So here you don't change anything for the cup position. So next is the type 1B, where your spine is rigid. So you can see that the pelvic incidence minus lumbar lordosis, you have a lordotic spine. The PI minus LL is less than 10 and the sacral slope, however, is less than 10. That means it is stiff. And that is where you need to change the cup position. We will talk about it because what happens is in these patients, the lordotic spine doesn't straighten out, the pelvis doesn't tilt back. So there can be impingement posteriorly and then you can get dislocation. So we will talk about that. So this is a clinical example. This is one of our cases. You calculate the PI and the sacral slope, and this is what is also known as a stuck standing. So the lordotic spine, which is there normally in standing position, remains lordotic when the patient is seated as well. So here you need to increase the anteversion of the cup so that you prevent a posterior dislocation. And then you can calculate how much of anteversion. We've given 22 anteversion in this patient. And the flexible or unbalanced is, I think I'm overshooting the time, but let's just explain this concept for the surgery to become easy. So flexible or unbalanced spine is, the spine is unbalanced, so the PI minus LL is off, but the sacral slope is normal. So there is compensatory mechanism. So here again, you don't need to do anything. This could be because of fixed flexion deformity or a contracture in a patient. And the final, which is the worst one, which you commonly see in ankylosing spondylitis. These are classic cases of ankylosing spondylitis. These are known as stuck sitting. What happens with them is the spine is actually stiff. The normal lordosis is gone. So the PI minus LL is actually more than 10 and the sacral slope is reduced as well. So in these patients, the spine is vertical. So when they stand up from a seated position, what happens to them is they can actually, you need to reduce the anteversion in these patients, because if you give too much of anteversion, you will get impingement in a standing position and the hip can dislocate anteriorly. So I think those are the important ones. This is an example, and it's a classic X-ray where you get a pelvic outlet view on an AP view. That is the stuck sitting patient. So these are the patients where you need to reduce the anteversion, and I think if you are using technology, you can do that and define your anteversion. So this chart is probably the most important. Type 1, 1A is normal, ignore it. So you stick to the standard figures of 40 and 25. If the patient has got 1B, that is exaggerated lumbar lordosis, here you need to increase the anteversion because these are more prone for dislocation posteriorly. In type 2A, again, you don't do much. These are flat back deformities, but they are flexible. So they will accommodate, and it's usually due to a fixed flexion contracture, which is reversible. The final 2B is the stuck sitting. So stuck standing and stuck sitting. So 1B and 2B. So 1B, you need to increase the anteversion. 2B is a ankylosing spondylitis, bamboo spine. The spine is straight. Here you need to actually reduce the anteversion. Or consider using a dual mobility cup in these patients. So this is a series that we have done about 150 patients now since this slide. And we have done about 35% of them robotically assisted. We use posterior approach for all cases. No dislocations, so don't get hung up with anterior approach or direct anterior approach. Vigdorchik has also proven it doesn't matter. And we don't have an early post-op dislocation. You can see that our patients are young patients. We still have 2B and 1B quite significantly. So nearly 10 to 15% of patients. So you need to understand the terminology and classification. I took a bit longer because I wanted you to understand it. You understand the importance of spinopelvic balance, and you need to understand how to dial in the cup positioning to that patient. Yesterday we talked about patient-specific alignment in TKR. This is patient-specific alignment in hip replacements. And I think gradually we have seen and we are moving away from the Levenick safe zone. And if you have some enabling technology with you to get your cup in the right position, I think that is where you will get best results. Thank you.
Thank you, Mahesh. Extremely well explained. We'll take one question each for each talk because the surgical case is already ready. So one question on each talk, please. Yes, sir, please. Yeah, please.
Well, kaise chalega? Yes. Sorry, Dr. Talwar, I was late. I didn't listen to your talk. The only thing is I want to share that, yes, pre-operative planning with templating is very important. And it definitely, literature says that if you do good pre-operative planning by templating, the limb inequality, limb lengthening is decreased to 67%. Chances are less. One. The only thing I want to share that I don't know whether anybody, there are so many hip surgeons over here, they are using templates or not these days. To me, it looks like that it has disappeared like dinosaur from the theater. But maybe the only thing I would like to share that I worked at Dehradun years back. So when you ask this company wala to provide the templates as a beginner, they usually try to intimidate you. They say, because most of them come from Delhi, NCR, they say कि पूरी दिल्ली में तो कोई यूज़ करता नहीं है सर, आप ही पूछ रहे हैं, फिर 3-4 रमनीक महाजन और 2-4 का नाम लेंगे. So they are not using it. Secondly, even if you insist upon, they will give you the photocopy of the templates. And the photocopier doesn't identify whether he is magnifying those to 110%, 120% or so.
Leave it now.
So it's likely that you might make mistakes. Now coming to Dr. Deepak Rana, in your opinion, if patient gets lengthening, which is the worst situation, having lengthening or say getting the limb a bit short than expectation?
Lengthening is less tolerated than shortening.
Patient psychology.
Patient-wise. Huh? So
Well-
lengthening is much less tolerated.
Well, I have absolutely a different opinion about that. When we talk to this patient, if patient gets lengthening, right, he is more agonized. because he thinks that other limb has also same, right, absolutely. सर हरियाणा में क्या है ना, किसी की भैंस मर गई तो उदास बैठा था, तो उसने क्या उदास क्यों बैठे हो, कहता भी आज 40,000 का नुकसान हो गया। कहते क्यों, क्या हुआ, कहता मेरी भैंस मर गई। कहता भैंस तो 20,000 की आती है। कहता 20,000 की खरीदनी भी तो पड़ेगी दूसरी। So
thank you for these comments, sir.
Last, Dr.
Yeah.
Kulkarni, Dr. Mahesh, one for you. When you change the anteversion on the table, does it affect the acetabular inclination also?
Yes. So if you change the anteversion, it's about 7 to 3.
Yeah.
So if your anteversion, if the inclination changes by 10, your anteversion changes by 3 as well. So from sitting to standing. So you have to
Because in
calculate
2 or
that.
3 cases I observed that when we change the anteversion and when post-operatively we look at the
Definitely it will
inclination,
change.
it changes.
So from standing to sitting as well, the anteversion and inclination will change with a ratio. And that has been a published ratio as well.
Thank you.
So thank you for the comments and thank you for the answer.
Can I just answer his original thing?
Yes, please.
Sir, जो कंपनी वाले कहते हैं ना कि टैबलेट कोई यूज़ नहीं करता, that's a wrong statement. People who don't have MECO or who don't have the trauma guide software should use the traditional templates in the right photocopied magnification. That you have to see. But template use नहीं करना is definitely getting into trouble.
We are using templates, even we are using MECO. We are doing both.
Yeah,
So
your work becomes easier.
we are ready with the live surgery over there. I request Dr. Mahesh to kindly give token of appreciation to Dr. Jatin, please. Sir. Sir, Dr. Mahesh, sir. For Dr. Deepak Rana, sir, please. And for Dr. Havindran, sir. And I request Dr. Mahesh sir to kindly moderate the next session also, please, sir. Sir, up stage, please. And I request Dr. Adarsh to come on the stage to moderate the next session. We are going live. Dr. Ramik Mahajan sir and Dr. Narayan Hulse sir are there. They have
request you to give the mementos, please. Dr. Adarsh. Yeah, thanks. Please. Yeah, Dr. Hemant.
शेड्यूल की कॉपी है
मैं दे ये वाली है, इसमें थोड़ा चेंजेस हैं। मैं एक मिनट में बता दूँ, मैं दे रहा हूँ। Yeah, heading on to the next session, please. So we have a next session on complex primary THR. May I request upon Dr. Samarth Mittal and Dr. Gurinder Bedi to moderate this session. Dr. Samarth?
Okay, so...
All right, we'll start. Yeah.
Okay, so this session is complex primary total hips. We all think that you guys are too advanced for any basic knowledge on hips, so let's push it a little bit forward and see if we can manage some difficult situations. So we got one, two, three, four, five speakers in this. Mahesh, I think you need to go early, so we're going to get you into this session. So just raise your hand when you need to go, so we'll give you 10 minutes before that. So every speaker gets 8 minutes. If Chandeep can make his way up to the dais. Any speaker who finishes before time gets a beer from me. Leave a time for question answer session if you can. It's always a great idea if you can get 1 or 2 questions thrown in. Chandeep.
So good morning, everyone. I thank Dr. Ramneek Mahajan and his team to giving me an opportunity to speak here today. It's a very difficult task to speak after a live surgery, and that too that well done a surgery. My brief today is to talk on hip arthroplasty for failed proximal femur fractures. We all know we are going to be facing them. We realize that hips do have their complications. We also realize the number and variety of implants available in India. Sometimes you're not even aware the implant that has been used or the companies that has been used. We have to assess the patient carefully and plan accordingly. That's the key. We have failures in femoral neck. We have had various implants available. We have screws. We have the angle blade plates popular amongst a lot of North Indians. We also have failures of FNS coming up now, and this is a very tricky implant to be taken out, to be very honest. Intertrochanteric fractures, increasing age, weaker bones, very high incidence. Surgical results are good, but we do have failures. And again, a myriad variety of implants. You have the DCS, you have the DHS, and the PFNs. So what next? The next depends on the age of the patient, whether the head is salvageable, and the local bone quality. My brief today is hip arthroplasty, and thankfully I'm in an arthroplasty conference. Otherwise, a lot of my x-rays will be questioned that why you're replacing and why you're not trying to salvage the head. So this is how sometimes the patient presents, and that's what needs to be done. So what all problems do we face? We need to handle the femoral side. So we have to look at the proximal femoral anatomy. You see the implants which are already there, which are a deterrent, which have already either taken away some bone or they are taking away that bone. You have an implant which is in a non-union, or you have malunions, a partially united or a malunited fractures. You have to mark the areas. You have to mark the areas where you have good bone. You have to plan in your head where you will get that hold. Obviously, you have to assess the bone loss and you have to manage it accordingly. Now, this is something, please have a look at the gift. This has happened to us 2 weeks ago, so happens to all of us. Don't hesitate to have a C-arm in your OT, and no, you are not a big surgeon by doing it quickly. Be careful what you do. Some peculiar problems of individual situations. In femoral neck patients, you have sclerosed screw tracts. So be careful of the point of entry that you make. Very popular fibula earlier used to be a problem. Sometimes we had to use a burr to take that out. Sometimes the fibula comes out completely as a single piece also. But fibula is seen less commonly, and now with the advent post-COVID of this bone grafting, you have bigger holes on the lateral aspect. So mark your point of entry carefully. Don't fracture that piece. In PFN, especially for anterolateral approach people, be very careful. The entry point of the nail is posterior. So if you're trying to take the nail out, be very careful of not damaging the abductor mechanism. Obviously, change in proximal femoral anatomy, so you have to ream. The use of the reamer, and the reamer as a sound, by meaning of sound that when you're going in, you're trying to feel where your femur is and not do what we just did. You have to assess the bone loss. There is a lot of classification, Paprosky and AOS being the most common. However, the key is to realize where your good bone is. In the type 1, you have a good metaphyseal bone. In type 2, the metaphyseal bone is damaged. And then you have 4 centimeter or less than 4 centimeters. This type 4 is less commonly seen in traumatic cases, more commonly seen in revision cases where the whole of the femur cannot hold a bone. So define the bone loss, define whether you have hold in the proximal metaphysis or diaphysis. Choice of implant usually is an uncemented. Cemented are reserved only when you have a good hold in the proximal region. However, then there are 2 choice of implants, the cylindrically extensively coated, the C or CR stem, and the tapered geometric design, the titanium stems. I would request you to go and read this paper. This paper has made us change our thought process and shift to a tapered titanium stem. The titanium tapered stems have a lower periprosthetic fracture rate, they have a lower thigh pain, lower subsidence, and lesser bone shielding and lesser bone loss proximally. And they do need only a 3 centimeter. However, we go by the dictum of trying to cover the stem length twice the femoral width. The other thing that we really need to focus on is the abductor management, abductor mechanism management. You have to be careful during your approach because the abductor mechanism has already been passed through. There can be a separate bone piece, there is a sclerosis. Don't erase too much of it, be careful. And if that bone piece is separate, wire it back and see the continuity before you come out of the OT. This is the intro-op video. This is a fast video as we have a lack of time, but sometimes the implant is used as a lever mechanism to get the head out. You have to clear all the tissues that are surrounding the acetabulum and the femur. When you are doing that, be carefully. Acetabular side, usually the bones are softer, as we saw in the neck femur patient as well, but in a post-traumatic case, patient is not walking properly, so be very careful. If your screw is going through, then you have to manage that bone loss, and that's the next lecture probably. Here you see that you are clearing the proximal femur. You have to get a good hold in the proximal femur, so clear it of all the muck that is around that area. Measure your stem length, see the trial, save that bone piece which is being saved there, clear that bone piece also so that that bone piece can stick back to your stem. And once you insert it and reduce it, you need to wire all these bone pieces carefully back together and get them in continuity. And reattachment of that last piece is the key, which we do at the last, once we put the final head in. So these are a few cases. These are standard cases. In my opinion, DHS removal is a far more easier option than a PFN1. This is the case that we just did. Just want to highlight something that, yes, you do have complications, and the complications are, most common complications is limb length discrepancy and dislocation. This hip dislocated, we tried a closed reduction, and it held. This is our case, the case that we have done and which taught us the most thing. This is a broken PFN implant. We thought we will be able to get it back out easily, but the PFNs are causing us more difficulty recently. Just to show that there is a small piece of bone here, keep a watch on it. This is what we did. We took it out, but in the process of taking out that PFN, that proximal fragment got broken. The greater trochanter piece got broken. We got it, wired it back, looks nice. However, it comes out. The lady is 95 kgs. You can see the thighs. So this comes out. Again, we tried a closed reduction done by the senior resident in the night. Thankfully, it reduced. Next day morning, this is the case again. So we had to go in, take in again, increase the offset, use a larger side head, and it's stable. So be very careful of the length, the tissue tension, and the abductor mechanism. Complications are dislocation. Early, you have to get the tissues right back. Late, the stem subsidence can lead to dislocation. Limb length discrepancy is the key here. I think the consenting is the key. Telling the patient that there is chances that we may not give you the complete length back. There are neurovascular issues also involved when you're going posteriorly and removing. Be careful of the nerve. Don't over-lengthen also to try and tighten the tissues. But here are certain situations that we try and leave the hip tight a bit. Perisprosthetic fractures, because we have curved femurs and straight stems, so be very careful of the tip. And obviously later on, thigh pain is an issue, whatever stem you use. This is just to show that intra-op, even the small screws can make life nightmarish for you. So this is where we actually broke 2 drills, screwdrivers, just to take these screws out. And this is just another take where we decided not to go after this plate and used a small stem. However, this stem is withdrawn, but just a thought that maybe you don't necessarily need to try and remove all the implants if you can somehow prevent it. So in synopsis, treat it like a revision arthroplasty on the femur side. You plan your incisions, Choose the approach you are comfortable with and which gives you access to your implants. Have things ready as in a revision case. Aware of the change of the proximal femur anatomy, see where the bone pieces are, save your abductor mechanism, get the good stem fixation where you need to, and use of a larger or a dual mobility head is what is needed at times. Thank you.
Chandeep, that's wonderful. The timings were absolutely spot on. While we request Dr. Malhotra to come to the stage for the talk on acetabular fractures, while he's making his way up, any burning question? Any one quick question? I think Chandeep can answer. I think the take-home points, I think Chandeep, never underestimate the implant. I mean, you can be caught out so often. As often as you can, dislocate the hip with the implant if you can, and then take it out. And make sure you got enough armamentarium ready if things go wrong, which happens very, very.
Even simple implants surprise you.
Absolutely right.
I think the smile on Malhotra sir's face says it all. I think he's going to present us something different. He's more of the opinion that the implant, if it doesn't need to come out, don't take it out. Right. Rather than taking it out after dislocation. Let's see his talk.
Absolutely. Good morning. I'm very pleased to see the chairpersons. And very good morning to all of you. So I'm going to talk about the total hip for acetabular fractures. And this is not an uncommon scenario for anybody who has been doing hip replacement. You know, it may vary from a few months to a few years. And interestingly, for middle-aged patients, it has been shown that the total hip arthroplasty does better than open reduction for posterior wall acetabular fractures. So still people are reluctant to do it primarily because there are reports of lower survivorship and more complication, but all cases have been reported for delayed THA. There are reports which say that the acute THA results are equivalent, as good or as bad as the delayed THR. And there are some reports, you'll find my paper also there, about the acute THA in acetabular fracture. But then most of the studies are retrospective and the literature is really sparse. So what do we lose when we wait for this? You know, you can lose the femoral head, you can lose the bone stock, patients are often not bearing weight, and then of course the hardware presence and the risk of subsequent infection. So I'm going to talk about what is the current role of acute TH in unsalvageable acetabular fractures, young elderly, choice of implants, special considerations, etc. So you do an acute THR in a young patient when they are both femoral head and acetabulum are involved, with severe comminution which cannot be reconstructed if there is pre-existing arthritis, fractures with poor prognosis which involve dome or posterior wall comminution, and there is an increasing number of osteoporotic acetabular fracture in elderly which need the acute THA more and more. And these are the configurations, patient factors and external factors which need acute total arthroplasty in acetabular fractures, like those fracture involving dome, posterior wall comminution, subchondral impaction, femoral head damage, elderly patients, acute pelvic discontinuity, osteoporosis, low demand, prolonged dislocation and delay to reconstruction. And most common patterns were the posterior wall and transverse posterior wall pattern. Again, you can see our cases were just like those reported all the worldwide. There are several challenges including distorted anatomy, difficulty to get stable fixation, need for special implants and instruments, and risk of aseptic loosening and dislocation. So newer porous metal cups are excellent solution for acute as well as delayed total hip replacement. They can aggregate thrombocytes and accelerate osseointegration, and they have good endurance against aseptic loosening. You have to wedge your cup between the anterior superior and posterior inferior columns, and most of the times it's the sciatic buttress bone which remains attached to the acetabulum, and that gives area for fixation. This is a case of young male with fracture dislocation, transverse with posterior wall. That's the intraoperative picture and immediate post-op, and that's the follow-up. 56-year-old male, fracture dislocation right hip, again treated 55-year-old chronic liver disease with polytrauma, and he had fracture fixations and acute total hip. So these cases were all done by porous metal cups. So we have published our results of acute THA using modern porous metal cups, 18 patients, 48 months follow-up with excellent result. You can use plates and fix, whether it's in delayed total hip with the pelvic discontinuity or acute THA. Then you can use the same approach or a different approach. 58-year-old male posterior wall combination, plated and total hip done at the same time, and continues to do well, though you can get some heterotopic ossification. This is 35-year-old morbidly obese lady with the road traffic accident, and this is the CT scan, and this had, I took the help of Dr. Vivek Trikha and this, the trauma surgeon. We plated this, and then did an acute THR, and on your right is actually the 8 months follow-up, and she's walking full weight bearing. Cages are a great help in patients who are 60 years or older. The incidence is rising. Like I said earlier, they have osteoporosis, pre-existing arthritis, or often complex patterns because of the poor bone quality. And in these patients, 1-year mortality rate is 25% after fixation, and rate to conversion is up to 28% at 2.5 years. So this is one in acute existing pre-existing arthritis of the hip with an acetabular fracture treated with acute THA. Sometimes this patient just turned in bed and fractured. And with this kind of severe osteoporosis, the low cost and the best solution is just to put a Birch-Schneider cage. And that's what we did. And actually, she could stand up and walk the same evening. So this has been published to do the primary total hip replacement using Birch-Schneider cages. 20 patients at the median age of 73 years, and all patients were independent walkers. And we also published our experiences with octopus cage, and that was in Journal of Arthroplasty, mid-term to long-term, mainly in unsalvageable or delayed presentation. Tackling bone defects may need the femoral head of allograft or the various other inserts. So this is a 55-year-old male, transverse plus posterior wall comminuted fracture. The CT scan showed severe comminution, head was damaged, and then deficient posterior wall with marginal infection actually could be tackled with the graft from the head and a multi-hole cup. And this is a 36 months. 47-year-old male, neglected fracture dislocation, HPS antigen positive, user of femoral head autograft, and again goes on to do well. So what do we lose by delaying THA? Again, like I said once again, that you can actually have, the biggest ticklish problem for me in practice is that if I get a patient who has been operated, which has failed, and the patient has got raised ESR and CRP, and the plate has been put through the abdominal approach, if there's Topaz approach, and then another plate by posterior approach, you actually are at a pain to tell the patient that you need the removal of all the implants, and then 2-stage, and then do this. So that's why somehow I think, and many of these surgeries which get infected last for more than 4, 5, 6 hours. Remember, any surgery which goes for more than 2.5 hours, it's got anyway very high risk of infection. We often ask them. So if you don't have a femoral head, you can use an augment like this, which works quite well. And we have some special instrument. This is a special screwdriver which we use, which actually makes it very easy in a revision or in acute total hip to put the screws. It does where the normal screwdrivers do not have the excess, and then we use special hardware drills to drill holes in the TMRS shell. So you can use cup cage. This is an example of severe pelvic discontinuity with combination and acute cup cage. All the femoral head were used to fill in the graft. 72-year-old male with acute pelvic discontinuity, and again an example of a cup cage. The dislocation is a bugbear of this surgery as well, and that happens because the bony landmarks are compromised, component orientation may not be ideal, and the muscles often are atonic. So this one which dislocated was treated with closed reduction and brace, and we have published our results with cup cage construct for these cases instead of and we used a Birch-Schneider cage rather than a TM cage, and we had 1 dislocation in 8 patients. I have my own sandwich technique which is published in Arthroplasty today for alternate layers, and that happens, that allows us to take care of the discontinuity also in many cases, and these are the patients who can be tackled very well in the face of severe deficiency. Heterotopic ossification and dislocation, like I said, are the major problem. Usually the prophylaxis must be started immediately. Example, had a dislocation, needed reorientation of the liner to tackle it, whereas in other cases where there were cages, sometimes the close reduction works, but at other times you may need to go in and burr the impinging offending factor there to get the stable reduction. Another extreme example, failure of early fixation and again treated with cup cage, had a dislocation, was revised with constrained liner and remained stable. So in my practice with cup cage, I started with ZCA cups, then trilogy liner, and I do the dual mobility shell now. And in our experience now, when the first 26 patients with the cup cage and ZCA or trilogy liners, we had 2 dislocations. In the 14 patients with dual mobility, we had no dislocations and 100% the survivorship. So to conclude, the modern porous cups are extremely useful for acetabular fractures if you are doing total hip. Dual mobility and cages are extremely useful. Again, fix and replace if required. THA should be offered to elderly, particularly with poor bone quality and poor prognosis. And armamentarium optimally should be arranged to minimize complications. This is the summary of the recommendations. And if you want to know all about total hip arthroplasty and acetabular fractures, this is an article for you to read. Thank you very much.
Thank you, sir. I would now like to call upon Dr. Mahesh Kulkarni for his talk on role of modular stems and revisions. He has to leave early. Meanwhile, we can take any burning questions if we have. I'm sure no one, sir, the amount of experience Dr. Malhotra has with fixing these acetabular fractures with total hips. Any questions at all?
The talk is in the next session.
Rajesh, can I say, I mean, I know you have a huge width of things, but this operation is a primary not for the faint-hearted. I mean, you better be very sure about your implants, your anatomy. It won't, I mean, for the guys who are not doing as much, this is not going to be an easy job at all.
Next session, may I talk?
Agreed.
And number two is, when you see the kind of
the
cases
talk
which
is
come
from
to
the
me
next
after
session.
failed fixation and infection, you will realize that sometimes it's just written on the primary case that is going to fail.
Yes.
Keep away from it if you can't do a primary total hip, but don't go in and try to do something which you are not competent.
Yeah, so I think the one element that comes out of the patient morbidity with this is quite huge. So if you do it two-stage like most of the people like me do, it actually takes you down almost about 6 to 9 months before the patient's actually sort of walking properly. So if you can manage, it's something to think about. But again, as I said, you really need to be aware of everything. And again, carrying somebody who's much more worse, if you are a dedicated arthroplasty guy, much more worse in pelvic acetabular surgery is maybe a good option in this situation. But the cup cage construct is such a winner in this kind of a thing if you can. Mahesh, we'll stop whenever you're ready.
Yeah, thank you very
As
much,
of
Gurinder, for accommodating me. Earlier, we all know the principles of revision THR. You need to have axial and rotational stability with the new implant to maintain the leg length and offset and optimize joint mechanics. The reconstructions options that we have in total hip replacements are uncemented implants of 3 kinds. One is an extensively porous coated parallel side, or what we also known as a cylindrical stem. The second is a fluted, tapered, grid blasted titanium stem, like a Wagner type design, or in the same design you can have modularity in the proximal body as well as the distal stem. Or you can consider impaction bone grafting with cemented stems or cemented femoral stems, which I am not going to talk about. So in revision stem segmentation, you can have in distal fixation, you can either have an interlocking stem, very rarely used. The second is the Wagner style, either a monoblock or a modular stem. Third is the cylindrical, extensively porous coated stems, like a solution or the echelon stem. And then combination of fixation is a long stem, metaphyseal loading stem, like a car or a S-ROM stem, which has got a proximal modularity. So how do we choose our reconstruction? We need to have good initial stability. You need to have a simple technique and reproducibility of that technique as well. You need to have that implant which is compatible with an ETO, and you need to think about long-term bone stock depletion. So you cannot use a stem which will lead to proximal stress shielding and problems. So you don't burn the bridges for further surgery in the future. These implants are mainly used, the S-ROM kind of a proximally fitted modular stem is only when there is available bone in the metaphyseal area which can be loaded, and you can preserve bone with this implant, but again this is not we're going to talk about. So majority of the surgeons, we started using the extensively porous coated stem for diaphyseal fixation, because that was the stem which was available to us. Very commonly is the solution, and then later on the echelon stem. Unfortunately, these were made up of cobalt chrome. They were bulky. They led to thigh pain. And because it achieved good fixation distally, and cobalt chrome has got the modulus of elasticity different than bone, it led to proximal stress shielding and bone resorption. So there were problems. Intraoperative fractures were problem. The scratch fit was to be on the, for a longer distance, you need to have to achieve the scratch fit with these stems. And you can either succeed with a bony ingrowth or fibrous or unstable fixation. They were very good in Paprosky type 1, type 2. 3A, they were good, but they, in 3B, if the diameter of the femoral canal was less than 19, they did well, but if the canal was more than 19, as you can see on the right-hand side, the failure rate increased quite significantly. The problems, as I said, with cylindrical stems like cobalt chrome stems were stress shielding, cantilever bending, there were intraoperative fractures. These were less forgiving stems to use for surgeons. And thigh pain was also very common because of the distal tip offloading. And the workhorse for the revisions currently in my practice is the tapered fluted stems, which is made up of titanium. However, there was criticism for the original design for subsidence and dislocation. But if you see that there was radiographically, it was leading to less stress shielding and the bone resorption was much lesser with these stems. So we had to check whether these stems were better than the cobalt chromium stems in achieving better quality of life, avoiding complications and preserving bone stock. And I think yes for all of them. They did have better quality of life scores, less thigh pain as compared to a cobalt chrome stem. Intraoperative fractures were less with these stems as compared to the cylindrical stems. And the bone stock restoration or maintenance of bone stock was definitely better with the titanium fluted tapered stems, or what we call as the TFTS stems. So the titanium fluted stems then were well established with wide range of indications for uses, less thigh pain, less intraoperative fractures, and good bone stock restorations. However, we all know about the original Wagner monoblock stem, which was launched in 1987. It had got rotational stability with the flutes, axial stability with the tapered geometry, and it had a grit blasted surface. It gives you good bony on growth onto the stem itself. But if you see, the slide is in yellow, subsidence of 12%, dislocation of 12%. The neck shaft geometry was a bit valgoid for these original stems. The offset wasn't restored, and they also underwent subsidence, which led to dislocations. So that was a persistent theme with the original Wagner, and you can see dislocations and subsidence were nearly high, 10 to 15%. And that is why the modularity in these kind of designs was introduced to take away, to care of the subsidence, and also you get the fixation distally, and then you have a modular body so that you can accept or adjust the leg length and version and offset quite correctly. So they were most useful in the setting of severe proximal bone loss, or if you've done an ETO, because it allows you proper visualization of connecting the proximal body with the distal stem and getting the Morse taper engaged properly. They have decent survivorship, decent mid to long-term follow-up as well. There was low risk of subsidence. The subsidence was less than 3 millimeter as compared to the monoblock stem, and that also settled with time, and there was low risk of revision. However, the modularity has its own set of problems. You are introducing another Morse taper, which is going to have problems of erosion, problems of metallosis, and also problems of catastrophic failure with cantilever bending and fatigue failures, and increasing weight being put on led to catastrophic fractures of these components. There were significant contraindications for this in high body mass index. If the femoral stem diameter was less than 19, and if you use modularity, the chances of fractures were higher in the original modular stems. If you undersize it, if there was proximal medial bone stock which was lost, you have to put a strut graft so that there is no cantilever bending, and implant loosening was also a problem. So how do you choose? When do you use a monoblock titanium stem or a modular titanium stem? If you are an experienced surgeon, you can actually get away with monoblock revision stems in nearly 90 to 95% of your revision practice, which is a Wagner or a Redap or a variety of modifications of this. You will have to just spend a little bit longer in trials. You need to see how much depth of insertion you want to accept, when at what level of insertion you are going to get restoration of offset and leg length. So, and sizing the stem is good as well, important as well. I use hand reaming. Some surgeons also use powered reaming, but the hand reaming gives me an idea of the amount of scratch fit and the level or the scratch fit that I am going to achieve with that stem. If you are infrequent revision arthroplasty surgeon, it is probably better to use a modular stem where you can actually put the distal part of the stem and use the modular stem with the length and offset options that you have, but better to have a ETO for that so that you can see the junction, engage that junction at the Morse taper very well without any problem. The recent studies with the monoblock Wagner type of stem have shown that if you use the correct technique, less than 6% have subsidence, and majority of that subsidence is under 7 to 8 millimeters, and that can be completely ignored. So in conclusion, the cylindrical stems which are made up of cobalt chrome are rarely used. Subsidence and dislocation with the first generation of monoblock stems were common, and that is why the modular stems were introduced with the titanium fluted design. However, they also have their own set of problems, like intraoperative fracture risk was very high and catastrophic failure at modular junction, but that again has been mitigated with better understanding of the junctions at the modular level. But the newer generation of monoblock TFTS such as Wagner have low cost, low subsidence and dislocation, ease of instrumentation, better availability, and it's much easier to use it in our practice. Thank you.
Thank you, Dr. Mahesh. Going from fractures in the proximal femur to acetabular fractures to use of modular stems in these, we go on to dysplastic hips, and I would now like to call upon Dr. Hemant Sharma for his presentation.
And Mahesh, thank you so much. I think that's the last we are going to see of you, as in this conference. And thank you so much. And I think on behalf of Mahesh, can I invite you all to the alignment meeting, which is going to be held on the 1st and the 2nd of December in Dinanath Mangeshkar Hospital in Pune. So it's a very exciting meeting. There's a full day talking just on alignment and knee replacement, and the second day talks about infections in arthroplasty. So it's a very good conference. I've had a look at the designs and everything. It sounds a very, very nice place to visit if you guys are free. But don't forget, you have one more in your city happening just about the same time. So you guys are spoiled for choice. So AIMS is continuing with its proud tradition of doing the current concepts meeting. So make sure you run between the two meetings and nowhere else. There's a buffer of 100. Quite right. Hemant.
Right, morning. So I'm going to be talking about the dysplastic hips. So sharing the possible complications I've come across. And thank you, Ramneek and team, for a wonderful conference. So they are challenging. We need a good planning. Apart from routine, please do a CT scan with a 3D reconstruction and a scanogram. I was not doing it, and then after a few cases, I again started doing a CT scanogram. Previous implants make it more complex, and they almost always need femoral osteotomy, because I'm going to be talking about only CRO 4, 3, and soft tissues, what soft tissues are really needed. So, of course, the standard approach is posterior. I read some papers about DA also, but it is difficult, especially if you have to do a femoral osteotomy. So you need a 360-degree exposure of acetabular. And is there a role of femoral osteotomy even before you expose the hip? So that's something what I started doing now. So obviously this is just an acetabular identification. It's a flat acetabulum. And if it's a truly dysplastic hip, your little finger will go in, nothing more than that will go inside. So this video I want to show you. In this, basically I put a wire in the proximal and the distal part, done osteotomy. You hold the proximal fragment with a bone holder and lift it up towards the head of the patient. So whatever structures come in your way, keep releasing it. So in this way, your acetabular identification is very easy, and you don't need to put a retractor in the anterior wall, because femoral artery and nerve is very close and people get femoral nerve palsy. And since the anterior wall is very thin, you end up having a fracture. The other thing is you can follow the inferior capsule. The posterior wall is always good, always have an immunointensifier, and start with the smallest sized reamers, which are like 36. And after 36 reamers, now I've started doing a reaming with a burr. This is a neurosurgical burr. So I don't use a reamer at all. I use a burr to deepen it. First reamer maybe to get a catch on the front and back walls, and deepening is done with the neurosurgical burr. And once you have a neurosurgical burr, you will feel your cup can go medial. It can be medialized very well, and my need for number 7 graft has almost come down. So there is more wall posteriorly. Use a screw if the coverage is more than 65%, and a femoral head graft if it is less than 65%. Now, number 7 grafts, lots of previous surgeries are done, and if there is an implant, it makes the life a little bit more difficult. So that's a number 7 graft, and I have a now follow-up. In one of the cases, I had to take it out because of impingement. So the trick is hold it with a 2 mm wire, don't drill it, straight away put a screw using a machine. Don't try it with a screwdriver, because it will move your hand and the graft will move. So this was a Wagner stem with a femoral osteotomy. I do not use graft for femoral osteotomy. This is one of my cases. I did a number 7 graft on both sides, young female, and she had impingement, so I had to remove it just a couple of months ago, but the surgery was done around 3 years ago. Now, high hip center. So when you cannot reconstruct, you think you can go for a high hip center, but research has shown 30 years follow-up study of 49 patients that the cup and loosening rate was much higher, found the cup and stem loosening at 68 and 29, whereas when the hip center was more than 3.5 millimeters. A lot of people accept it. I do not accept it. There are certain cases where I've accepted. So the figures of cup and stem loosening reduced from 35 to 18% when the hip center was less. This is one of my cases, very old patient, 65, bilateral DDH. One side I could get it. On the other side, the bone was very weak, so I chose a high hip center. Femur is very narrow, and they may have a previous implant. Hip is too anteverted, head is very small, the bones are osteoporotic. If the femur anteversion is less than 25 degrees, monoblock stem can be used. But if it is more than 25, then you use a modular type of a stem where you can control the anteversion. Now tissues. So you need to release capsule, you need to release rectus, you need to release iliopsoas, you need to release ITB band, gluteus maximus tendons, adductors even before you start the surgery, and in some cases, biceps femoris, lateral intermusculum septum and hamstrings. I always do that. Before femoral shortening, I do these releases, and it has now reduced the incidence of femoral shortening after you have done a release. If the stem reduction cannot be achieved even after these releases, then you have to consider osteotomy. So this is a femoral osteotomy. You make a transverse cut, put your trial implant inside, reduce it, see the amount of overlap, and keep cutting it. So there are different ways of doing an osteotomy. I do a transverse. Now recently in a couple of cases I've done an oblique. So subtrochanteric osteotomy can be transverse, oblique, or there are many other shapes which have been described. So this is a simple transverse osteotomy, no special instrument, overlap it, whatever part of overlap is there, you cut it. I don't use a graft anymore, this is a book picture. So this is, first cut is made 1 centimeter below the LT at an angle, which can either be up or down by 45, and the second cut is made exactly in the same direction. So that's a step cut osteotomy. I find it quite complex, I have not done it, no experience. So non-union of osteotomy site, 2.8 to 7.1%. Prevention with plate and screw fixation, I have never done that. Claw, hook and cable plate, I have never done that. Yes, I've had osteotomies, the non-union, then I have to revise it. I don't think so plate will work if your stem is loose and is not fitting in the canal. Now, no osteotomy THR. This is for bookish purpose. Books have described that you can do a 2-stage surgery. In the advantage is no risk of non-union, no femoral shortening, no internal fixation. So they're doing a femoral head resection, soft tissue release, putting an external fixator, bringing the hip down, and then after 2 to 3 weeks going back in. I think none of the hip surgeons would do a hip surgery after external fixation, so there has to be cooling period. Yes, it is described if you can't do it, but I've never tried that. And adductor tenotomy. Lesser trochanter is, if it is at the level of teardrop, you have to do an osteotomy before the exposure. Don't waste time. Straight away do a femoral osteotomy, expose the hip, and then go on. Identify the true hip center, use the smallest reamers and screws, as I said, if the coverage is less. So single stage, difficult to reduce the hip. There is a risk of nerve complications, inability to achieve good horizontal offset. So cut the neck as low as possible and tell your anesthetist to use a powerful muscle relaxant. Femoral nerve is injured. You won't come to know. Only physios will tell you the patient has got a buckling. Do not put any retractors inferiorly. Femur fractures 5.2 to 26.8%. I always use a prophylactic cable. I never had to use a wire or a plate fixation. If canal is small, don't worry, split anterior and posterior, put your stem and then wrap it up. So leg length discrepancy, anxiety, depression, asymmetry of more than 1 centimeters. What are your options? You can either shorten the same leg, I have done it, or make the other leg longer, which I have never done it. In my experience, nerve injury happens because of extensive diathermy use near the gluteus maximus insertion or a leg length of more than 4.5 centimeters. So this is just prophylactic wiring, osteotomy, cup sizes should be small, Wagner or S-ROM, cemented stems should be available. Ramneek has done cemented stems with osteotomy. I have no experience. Neurosurgical burr and femoral shortening should be done. So poor bone stock is a big complication, and you have to do massive soft tissue releases. Now this patient, dislocation, this is, if you can see, there was a wrong choice of the graft. So they have taken away the inferior part of the pubic rami. So I don't know what is done. So it dislocated. This is the 3D model, and you'll be surprised. But I know this has been reconstructed elsewhere, but I don't have a clue. This is one of my cases, all three complications: non-union infection, heterotropic ossification. She's walking. I decided not to do anything. Intraoperative fractures, you have to go back, fix it. He's walking, healed very well. Leg length after surgery, patient was very disappointed. I had to do a femoral shortening on the same side. He's happy, no cordyceps lag. Dislocation, as I said, is very common. He sat at the airport for the prayers. I've had nerve injuries, most of them recover. 6 weeks, 12 weeks, 7 months, complete recovery. Thank you.
Thank you, Hemant. But Hemant is actually not just good at his hips as well. If you want any advice on how to do a reduction osteotomy, he's done it on himself. So what you see of Hemant today is half of what he used to be. So he can give you some advice on that as well. Well done on your fitness drive. Guys, can I just request? We have a lot of stalls outside, and we depend every time on the sponsors to keep these kind of meetings happening. Please make sure when you go out for tea, coffee, lunch, whenever you go out, please do go and visit these stalls. We really need to go to them the next time again as well. Can we now request Ramnik to talk on protrusion hips?
I think Dr. Bedi has already talked about the upcoming CCA on 1st to 3rd of December. For all these difficult cases, revision hips, there is a cadaveric workshop in the CCA coming up on the 1st to 3rd. It will have a lot of foreign faculty, around 7 to 10 foreign faculty, and 2 cadaveric workshops on complex and revision total hips will be there. So everyone is invited to please join.
Okay. Vijay, are you looking for live surgery cases as well? Not that you ever have a shortage of them.
No, he doesn't have shortage, he has plenty.
He has too many.
I was waiting for him to raise his hand when I wanted one. Now I'm filling in for Dr. Rajkumar. For some reasons he couldn't come in. So that's protrusio acetabulum for us. I will not go much into the theory part of it. About the medial wall protruding in, you all probably know this, and the medial displacement of the hip center. That's what a protrusio would look like. This is one of the severe cases when they don't come in, and with the neck femur they suddenly land with you. And this was in the peak of COVID when this lady actually came in. So I'm not going to the philosophy, the theories of it, or what happens with protrusios. That is in the books, you go and read. But the diagnostic criteria would be the standard X-rays, of course the C angle less, protrusion medial to the ilioischial line, violation of the teardrop. I do a CT only when I need to look at my integrity of my boundaries. How do I want my cup to look like in MRI if I suspect something else for this protrusio? That's what comes from the book. Mild, moderate and severe is how you classify your protrusio. And what are the principles in reconstruction if you have a protrusio? They always talk of restoring the anatomic geometry, center of rotation. I always say, I learned it from Dr. Pradeep Sharma. Actually, I assisted him in quite a few cases. And in my initial days, he was my go-to man for hips. And he was very clear that if you bring it right down to where the center of rotation actually is, you will have difficulty in putting it back in. To lightly leave the cup slightly medial. And over the years, I realized that probably was the best way to do it. Then, of course, the leg length offsets can be played around, and lateral and distal transfer of trochanter for abductor biomechanics. I remember assisting in one when we actually went in after 6 months to do a trochanteric osteotomy to get that patient back. Principles in reconstructions are problems with dislocations, mostly seen in progressive cases or with contractures. Avoid forceful dislocation maneuvers. So if you're not able to reduce, that means probably take out that cup, medialize it, you've probably either impacted a lot of bone medially behind that cup. And if you're actually not able to, in the exposure, not able to come out, do an in situ neck cut. Do not try to bring out the head like you always do. Just do an in situ neck cut. And of course, don't throw that head away. That is precious than gold. Not wide exposure, medial wall, cleared of soft tissues, define your borders, ream to a peripheral fit, avoid small reamers. When you're going too medial, just don't use small reamers. You know it's already a soft bone which is medialized. Just rim reamers and that should be okay. And of course, trial placement can be checked on C-arm if you're not careful. So that's how the transverse ligament and the depth, you can actually look at it and say how much in the transverse ligament you can want to be. Always graft the medial wall. Impaction bone grafting is a very good technique. Please learn that. And you have a lot of head there. In case there is a soft bone, you can always put in a mesh behind that. I'll tell you why. Head as a bulk graft, and of course in revision cases you have everything like rings and cases. So that's how when you're looking at, that's the view you probably will have when you're putting in impaction bone graftings before you start impacting. And as you also, this is a book picture where you say that you put in your trial and everything, and this is how you actually do not want to be at that transverse acetabular ligament. You probably need to be slightly inside the transverse ligament in most of the protrusio cases. So what are the principles in reconstruction? Porous coated cups, rim fits are more important. Avoid medial wall reaming, supplement with screws, lateralize I've already discussed. Avoid inadequate restoration, these are principles. So this is one of this Dr. Pradeep Sharma's case, by the way. I am starting with his case because this was when I was learning, I took that photograph at Orthonova Hospital. And that is how this was the protrusio. Planning was done. That's where we decided the cup should be. And this is what was done in that particular case. Sir, I still have that photograph. So I wanted to start actually to pay him that respect because I learned protrusio from him. Now this is where in one of my cases, this is what I do in all my protrusio cases, that the first reamer that I want, I just put it inside. So the reamer is in, now I know what depth I want. And then this is one of the cemented cups that I did in this particular case. That's another case where, that's where you want the cup to be. That's the ilioischial line. This is the amount of defect that needs to be taken care of. And this is what I did. I'm sorry for the audio. So this is in situ neck cut. I just did not try to come out of it. And again, where's Anup? Anup was here. So I learned this from Anup. I discussed at one of the conferences I was presenting, and Anup then pointed out in a question that why did you take this head out? That head is already there for you. Why do you need to take it out? Just ream into the head. And so that is what we did after the neck cut, and we took out a good biscuit. So once you have that good biscuit as a triangular wedge of bone, you can actually just dislocate the head, leave the head there, that the smart, you can see the biscuit will just come out, and you can, that is it. You've done your neck cut, you've done everything, the biscuit will just come out, and that's it. And after that you are there. The head is already inside there. So you don't take out the head and just start reaming into the head. So the graft is already there for you. So you don't need to do anything more than that. You can ream into the graft, leave the head there, and once it is done, look at the bottom screen. The bed is nearly there for you. You can just go ahead, prepare it, finally leave that whole thing inside, and the cup is there. You really did not do anything more than just reaming into that head. And that's the transverse acetabular ligament, and the cup is just sitting inside. And that's the post-op X-ray. So going forward, another case, what I also start doing a lot of times is, after I've done this, onion peel slices. I would just take that head out. If the head actually comes out in some of the cases, I would just cut them in this onion peel sizes, and I would use them, impact them inside. You can see on the left screen, you place each onion ball inside and hammer it, hammer it, hammer it. And as much as you want, you can just hammer. And then keep checking. If you think that you've lateralized enough, that's it. And then you can put your cup in. Anup, I just paid regard to you. You were not here. I just showed you a technique of leaving the head inside and do an in situ cut, leave the head inside and ream, which I learned from you in one of the conferences. I'll take a cup of coffee from you later. So that's the case wherein we just went in, didn't do much, and lateralized and came out in an old fracture. This is the case which I just showed you, 49-year-old female, one of my cases. Got it her in the peak of COVID with a fractured neck femur. I thought I'm smart enough, so I did this, did my grafting, did everything, and I thought done, and I gave her a date, 6 months down the line, we will operate again. Okay, so second hip. June 2020 was this. She didn't come up, and 15 months later, she actually came with this. So the bone medial was so soft that even after my impaction bone grafting and everything, it just didn't heal. And that is when I realized I think probably I should have put just a mesh there to protect, and I should probably have cemented her. She was on bed for so long, whatever be it. So I had to go in and put in a cage with a lot of allografts. On September 21, and this was 6 months post-op, she was doing well, mobilized, and as luck has it, she does not want the second hip now. So I'm waiting for her to come with the fracture. Post-tuberculosis hip, again, you can use a C-arm like this, intraoperative, if you're not very comfortable. And that's the post-op X-ray of the same patient. Well restored. Another one, same thing. So I'm not much into it. So this is something, yes, a 73-year-old female with a trivial trauma. And this, I will not take time, sorry. That's the head comes out, acute fracture situation, we put in a cage, got her out. So take home message, problems with normal offset restored, tight reduction, never over lateralize, use a femoral step with a high offset, aim for peripheral rim support, impaction bone grafting, and avoid limb length, a low femoral neck cut, and a high medial offset stem. Thank you so much.
Thank you, Ramneek sir. Now I would like to call upon Dr. Rajiv Sharma on his talk on subtrochanteric osteotomy.
So guys, we will have time for questions. The priority will be given to questions from the audience. We have a hell of a lot of talent in this room. If you have a look, even, I mean, something like Dr. Sadhu, who's not been asked a question till now, needs to be harassed a little bit. He's getting too comfortable in his relaxed life. Dr. Pradeep Sharma, Dr. Gill, they're all such stalwarts here. Do not let them get away without asking them some very, very difficult questions. Rajiv.
Thanks, Gurinder. Thanks, Amrit. Thanks, Ramneek, for this invite to this wonderful meeting. And I'm happy to see that on a second day, the good number of in the audience. It means that Delhi arthroplasty is becoming stronger day by day. Thank you so much. So I've been asked to speak on subtrochanteric osteotomy, and some of it has been covered by Hemant already. Now, subtrochanteric osteotomy, before we go into the subtrochanteric osteotomy, the dysplastic hips have three options and three major issues: plastic rigidity, significantly abraded hip, and significant limb length discrepancy. Now, these are the things which are to be sort of managed. If you have a upridden femoral head, you have three options: whether you release it and bring it to the anatomical center, or you accept the high hip center, or you shorten the femur. Here you have a patient where you have the extensive release, CRO 4, brought to the center and use the bone graft, and patient is doing well. Another CRO 4, no osteotomy needed, brought to the center, the hip to the anatomical center, and you can see that patient is walking well post-operative. In another patient where you are not finding it easy to bring it to the anatomical center because there are a lot of fibrosis around, a lot of stiffness. So you accept the high hip center provided you have the sufficient bone in that area. But then if you don't have the option, if you are not able to bring it to the anatomical center and you force it, so this is what can happen, like in this patient, that you can actually they damage the whole proximal femur, and as a result you will have a dislocation, and also because it's a long surgery, obviously you may encounter the infection, as in this case we had to treat it with a 2-stage revision standard, and that's how this patient ultimately needed a mega prosthesis. So this is just to show that subtrochanteric osteotomy, if it is needed, it must be done. There is no way that you can avoid it. Indications: you have an anteversion more than 20 degrees, more than 5 centimeter limb length discrepancy, when you want to protect the nerve, and you are not able to bring down the femoral head, and neither you are ready to accept the high hip center. It's very easy, determine the level of the subtrochanteric osteotomy and then go ahead. The one example, you have a CRO 4, do the osteotomy first before, and that will help you identifying the acetabulum also, and just bring it up, release all around. You can just leave up to the abductors. Apart from abductors, you can release significantly in the proximal fragment, and then you will find that it's not too difficult to find out the cup, and then you go on in the routine way, and that's how you find your bilateral subtrochanteric osteotomy, and you have been able to bring it down to the right center. Another example, young girl having this stiff hip, upridden femoral head, And that's how you do the subtrochanteric osteotomy. Right in the beginning itself, you can mark with the cautery first. You can mark with the saw or high-speed burr that where the osteotomy is going to be reduced. And then just to put the 4 marks so that you can align them when you are finally reducing these fragments. You can do the saw, you can use the multiple drill holes. Ensure that this area is not having the thermal necrosis because of the saw. Then you see that you have released this proximal fragment significantly, and that helps very well. And you can have a preliminary cut of the distal femur, make multiple drill holes. If you use this saw, you must use lot of saline so that the heat necrosis is avoided. And then you remove it. You can use this removed segment, divide it into 2 halves and put it with the cable or the steel wires. Then you ream the routine. Proximal fragment also. Retrograde reaming could also be a very easy way, because minded all these patients will have a very narrow canal, sometimes just 6 millimeter or even narrower than that. That's how you know that you are now able to reduce it. And then you can, if you use the modular implant, you can change the rotation, the anteversion of the neck in an easy way. Use the steel wires, use the removed part of the segment, divided into 2 halves, and fix it up nicely with the help of the wires. And that's what you see post-operative. Another patient having the one side only, you use the femoral head, because these are very small cups. You can fix the femoral head, and then after start reaming. That's how you see. You fix you remove make the osteotomy, shift the proximal fragment anteriorly, superiorly, and identify the cup and keep reaming. That's how you see. And use this removed part with the cables or the steel wires. And that's what you see this patient 6 months post-operative. Meticulous preoperative planning. Identify the osteotomy site carefully. Prevent combination of the proximal fragment. And identification of the true acetabulum is easy with the subtrochanteric osteotomy, and avail all sizes of the acetabular implants. Sometimes I have used as small as 38 millimeter cup, so they all have to be ready. Thank you so much.
I think with that we finish the talks of this session, but now we have a panel discussion, so I request all the speakers to kindly sit while I call upon the panelists for this session. Bedi sir, Dr. Pradeep Sharma,
Sharad, Dr. Sadhu, and Dr. Murthy. Okay, guys, this is your chance. Here's the chance to ask some very difficult questions. Good to see you back, boss. Okay.
There were a lot of questions regarding robots during the dinner time. I think Dr. Vijay has just told us that during the CCA we'll be having a robo world with all the 5 robots from all the 5 major companies sitting in for hands-on workshops and sawbone workshops during the upcoming CCA.
Yes. ये ठीक है?
Hello.
ठीक. So we have some cases for discussion, but we'll do some. The priority is questions from the audience, like you.
So I would like to nudge Dr. Sadhu and Dr. Pradeep. You have a very large experience of a lot of years, and you're extremely silent, both of you. Very unassuming, both of you. So let me just ask you very briefly, 5 points of 30 years experience both of you must be having. 5 learning key tips from both of you. Hip replacement, regarding general about hip replacement. 5 key tips and tricks, whatever comes from your heart.
So I can tell you, as he just said, I mean, we've all sort of, grown up seeing these gentlemen, and they are genuinely the stalwarts, the guys who actually started more arthroplasty and everything out there. So that's why I think this question is so poignant out here. Dr. Sadhu.
Okay, I take it is for any hip replacement. Dr. Chorani? Okay, okay. So that's pretty basic. I can handle that. And if I don't reach 5, Dr. Sharma will take care. I think the first one, as has been hammered since morning, would be planning. It really is important that you are aware of the problems that might arise. Secondly, you are able to tackle those intraoperatively. Now that could mean having a various paraphernalia of armamentarium, including the wires in case you break the shaft. So that is planning. Secondly, adequate incision. The wounds, as everybody knows, heal from side to side, not from end to end. So give adequate exposure. If you can't see, you can't do. Third, respect soft tissues. There should be no crunching of the margins by a very vigorous Homan placement. Fourth, always aim for so-called reproduction of the hip center, whether you compromise for some reason at a higher hip center, well, that is debatable, but probably sometimes you are forced to do that, but always aim to put the acetabulum where it ought to be. And I think finally, the intraoperative check, that is, let the hip go through the normal range of movements, i.e. in your mind's eye, make the patient sit on the chair, at least do the rotation part, especially the tricky parts, that is the internal rotation. If there is any kind of problem that is arising, for example, dislocation, you really have to tackle it there and then. Do not leave the operation table hoping कि सब कुछ बाद में ठीक हो जाएगा. It won't. And once you are there, it will be relatively much easier to tackle it than to come back next day with a shame on your face. So even intraoperatively, if you get into some problem, there is always help around. Seek people who are far better experienced than you, and just give a shout. I honestly don't think anybody would mind coming, dropping everything, because they have been through this before.
So I think that's, it's a very valid, I mean, at that time you're in a lot of tension in your head and everything, and I think all you need is somebody, even if he's not more experienced, even a junior person. In fact, for a lot of us, even a technician who comes to help us out with the implants and all, sometimes they come out with the best of suggestions at that time, which really works. Dr. Sharma.
I think most of the points have already been covered. One is to always realize and understand the sounds of the bone. When you are impacting hard, when you are putting in your stents, when you are doing impaction bone grafting, learn the sounds of the bone and understand where you've got to stop, right? So that I think you get with experience, and you soon start realizing as to what kind of a sound is an altered sound and which is an acceptable sound. Right? So that is one, and I think have everything in your armamentarium. Once you have very difficult cases to do, like some cases Rajesh has shown, are mind-boggling, and you wouldn't know what would be used when. So I think you need to have everything with you available, right from the kitchen sink to everything that you could, so that you are absolutely sure that you would have everything in the armamentarium to sail through the surgery. And you should know your extensile approaches. Right? Don't get stuck with small corners. Don't get stuck with small exposures. Right? Learn how to sort of expand the approach and get into the bone or to the areas where you really want to. So these are some of the things. The rest has been covered by Dr. Sadhu. And I think that should be it.
Okay, I think we have a question from the audience.
Sir, I had a question regarding high hip center in managing difficult dysplastic hips. In your presentation, sir, you have mentioned we can go up to 3.5 millimeters. Some publications have even mentioned we can go up to 10 millimeters to 12 millimeters. What would be the go-to number for you? Up to what extent would you maximum go? Number one. And number two, what is your experience with patients getting those high hip centers, probably on one side and not on the other side, and then coming back to your OPD? Thank you, sir.
Thank you. As I said, this text was taken from the book. I personally never put a high hip center except in one case. Patient will never be happy if one side is high hip, one side is low hip. Yes, in elderly patients, people who are, like 50, 60, and they come for a neglected DDH surgery, there you have to explain it to them because bone has not bone weight, so it is quite weak. So I would not accept a high hip. You can use number 7 grafts. You can use different technique, Arthroplasty if you want, if you've got a poor bone stock. And 1 centimeter is acceptable, but I've shown you the 30 years follow-up is showing significant difference in the failure rates of a high hip, not only in the cup, but also in the stem. And secondly, offset is never balanced with a high hip center. And DDH patients have a very small offset. You need to balance them.
But it's not really that easy to identify the hip center. You can only plan it on a pre-op planning, and you understand this is where I would want to, and this is where my cup is. But intraoperatively, obviously, unless you, even if you take your SIAMs and all, you're only going to ever see that one acetabulum in one shot, and you're never going to be that good. So a lot of it, am I right, Hemant, is a pre-op planning?
Yeah, as I said, you follow the inferior capsule. You are able to see the acetabulum, true acetabulum almost always. And ever since I've started doing the femoral osteotomy for my exposure, it is damn easy.
So
Believe me, it's very easy.
What about the TAL? I mean, is the TAL still a very good landmark?
No, not at all, because the anatomy is disturbed. So you just have to go by your structural, anatomical, and all other alignments to put into the correct version.
Rajiv, you want to say something?
Yes, Gurinder. When you accept the high hip center, any hip center above 1 centimeter of the natural anatomy is considered as a high hip center. You should accept it in situations where you are having a lot of stiffness, a lot of fibrosis around the proximal femur, and these are the cases where the release will be very difficult. So these are the cases where you are forced to accept the high hip center. When you accept the high hip center, make sure that the bone stock is good.
Sure. Okay. So you're chasing a good bone and saying very.
That's right.
Dr. Sharma, tell me one thing. So when you want to bring it down, in your opinion, I can understand people talk about trabecular metal wedges and everything which you can put. We can even put a number 7 graft or something. We can even put a bulk. But it's not, in my little experience, I mean, it's not that easy, because when you mesh up the bone and you're pounding and pounding and pounding it, invariably it will actually dissipate, and you won't, where you thought it might be, by the time you get the cup, it's not there. It's always slightly higher. What's a better way to get the hip down?
No, except the high hip center. If you really can't get it down,
right?
Except where you can safely put
anything in a youngish kind of a person where you think, look, I really want to restore anatomy. Anything else you would suggest, Murthy? Or any suggestions?
I won't accept hip center higher than 1.25 centimeters. So you have to bring it down. But
so how?
Yeah. But if you are able to put it at 1.25 centimeters, put a smaller cup and get away with it, but not lateralize. Always hip center is good, but lateralized hip is not good. One. Second is, by doing osteotomy, whatever cases I have done, I could bring my hip down to almost to the hip center. I have a few number of cases of DDH.
No, I hear what you say. My question really is
no reason why you cannot bring your hip down. You have to release the abductors from the iliac crest, bring it down as much as possible, bring it down, do an osteotomy. While doing a trial reduction, see how much of osteotomy you would like to do it, and you can get it there.
Sure.
So I think to answer your question, I hope you've got the answer. So if possible, get the hip center back to what it was. If at all, if you have to get it higher, so try to get it within 1 centimeter, and patients will not be happy with a higher hip center. I think the only person who will be not happy, more unhappier than a higher hip center, is a patient who is called elderly at 50 or 60 years of age. Most of our faculty here would not like that, but even a patient with a higher hip center would not like it. So if we have any other questions from anyone in the delegates, I think we'll take that as priority.
Gurinder, you asked,
Else we start, I would like Now I have to call Dr. Murthy for his case-based discussion.
Samar, just one comment.
Yes, sir.
Yeah. Gurinder, you asked a very right question, very apt question, that how to bring the, how to identify and what is the use of the TEL in today's time. I think the TEL is important from the point of view that in routine cases, it's a very good indicator. And in where you want to change your version, the TEL still is useful because you can understand that where you have to change it. And one good way is that put a Homans retractor just below the TEL, and that will be very easy because that is the place where we, and then you can identify in an easy way.
Murthy. You can use a CM if you have got a doubt, and you put a probe in and put a CM. Yeah. How do I change this? Can I have the next slide?
Lunch time, yeah.
Yeah. This is an interesting case in the sense he has 50 years already Dr. Chandeep has already presented. So this type of patients I would like to highlight a certain points. This is a 50-year male. He had a intertrochanteric fracture, so they have done a PFN. For some reason, I think they used a proximal femoral plate also. So they used both in situ, and then patient still had a non-union in implant failure. He was completely almost bedridden or maybe mobile with a wheelchair for 2 years. So 2 years back it was operated. Second operation was done because the PFN screw migrated inside and impingement. Patient was having severe pain. So with that, somebody removed the screw and did not do anything more than that and left it alone with that, and still patient was on a wheelchair. So that this was the presentation when he came, that he was on a wheelchair, very painful, 50 years male. For last 2 years he did not walk properly. How to change it? Yeah. So this was the X-ray which I got it. There was a complete non-union, no active SLR. Patient was not bearing weight, and it was very painful, and there was a lot of swelling out there.
No evidence of infection.
Yeah, I'm coming to that.
All right.
Have some patience, Vedi. Oh, thanks.
I can. Yeah. These guys don't let me have patience.
Back a second. Yeah. So this was the X-ray which I got. So what will for the young guys out here, because it's a case presentation, right? Sure. So you were right, ask the right questions, and would like to now know.
Sharad, can you take that on, please?
Right. So they attempted to fix the femur by nail as well as the plate initially, and then subsequently there is a fracture in the neck.
I think it's nail followed by nail and plate followed by us.
So what was the sequence of that? Why did they do it? I mean, they would know it the best. But right now in our hand is the implant. There are 2 implants lying in the femur, and there is a neck of the femur fracture. Right. Now we have restored the anatomy so that we are able to make the patient stand again. And the sequence has to be removal of the implants first, and then simultaneously look for infection. And I think maybe at my case, I like to wait for, go for 2 stages. First remove the implant, ensure the infection, wait, and then go for total hip replacement.
Yeah, can I add something? This guy has got a CKD, creatinine is 2.3, anemic, 7.5 hemoglobin, and a very weak looking person.
So Shikhar, do you not think it would be wise to just, I mean, if there is no hardcore evidence of infection, I understand, I mean, multiple surgeries, infection chance and everything. This guy is not a great candidate for doing much. I mean, one stage, provided CRP, ESR normal and there's not much infection, maybe an aspirin.
They always remain very dicey, the ESR, that CRP, those things remain very dicey.
Immunocompromised. Chandeep, in your hands, 1 stage or 2 stage, CRP normally is, CRP is like 10.
All other parameters are normal. Aspiration was
in your hands, implant removal.
Single stage, but consenting will clearly involve that more than higher chances. Normally what the statement we use is, if it is 4 to 5% for a primary this thing, then in these cases with 2 surgeries, this chances of infection are around 15%. This is written, documented. But single stage, now see the problem is, you're talking the patient has CKD, hemoglobin 7.5. he's right that you can do two-stage as well.
Sure.
So you always take the
Aspiration
what
was
if inside
negative,
you open.
TLC was normal, ESR was
So my
normal.
question to you, Dr. Bedi, what if inside you open there is a sliver of bad-looking tissue? What will you do?
Frankly, I'll be very, very keen to do a one-stage surgery given a chance. I understand he's immunocompromised. I understand it's an endoprosthetic replacement, so high chance. But I think I'm going to be having, he will show a lot of scarred, unhealthy.
So plan for a single stage, but keep a standby spacer ready.
That's what I want.
Perfect. So, yeah, so comorbidity, hypertension, hypothyroidism, chronic disease, anemic, ultrasound guided aspiration was done in the hip, and culture sensitivity was done both for bacterial and fungal, and it came down to be negative. So optimization of the patient was done. I had planned for a single stage, but with a counseling to the patient that in case I find anything, and I'll be sending the frozen section as well as intraoperative cell counts, and then I'll do a two-stage, otherwise I'll do one stage. Dr. Malhotra.
Dr. Murthy, aspiration in these cases never yields anything, even if it is infected, because it's the implant-associated infection. I'm yet to see any case. I must have seen more than 200 of these cases.
but-
The aspiration never works. That's number one. Number two is the ESR and CRP are always high. And when the ESR and CRP are high, when you go inside, you will always find what he is telling is from the experience. You will always find some dirty tissue. So this is the question which is being essentially asked is, that if a reason for doing single stage is multiple comorbidities, do those comorbidities not make that patient more prone to infection? Yes. If you do one stage with a doubtful ESR, CRP and some dirty tissue, that's the question. I am yet to find a case where we didn't find these things. Yet to find a case failed where ESR, CRP was not high. Yet to find a case where there was not some dirty tissue. So the reason for doing one stage is also the reason for high propensity for infection. So for me, there are always two stage and never an aspiration will work. You can take out that implant, do sonication and try to look for the bug.
Yeah,
But,
Hemant, one stage
I
or
think
two
I
stage?
would definitely go for two-stage.
Chota jawab.
Two-stage. He's 50. He's not physiologically 50. You want to get rid of him of pain. Right after two-stage, he may become better physiologically. If not, he can still live without it. But it's not necessarily you have to do a hip replacement.
The basic issue in this patient is that the implant, maybe you have a strong suspicion of infection, so you have to take out the implants, and not just the implants, because you have a thought about the second stage. So you ream out the femoral head also, ream the femoral cavities well, so that the whatever possibilities of the infection are there are reduced, minimized and managed as much, because that will also manage his kidney status.
So finally, because ESR was almost 38 or 40 years there, and CRP was within not more than 2 times, and aspiration we did under ultrasound guided, and because the swelling was there. You're right, I did find a lot of debris out there, which I sent for. We have a frozen, because it's basically a cancer hospital, so easily they do a good frozen section. 4 places I usually take it. Did a good saline wash with 12 as usual as for the protocol, and I did a single stage in this case. So the patient this was done, and as Dr. Chandra always fix it up, the trochanteric fragment as much as possible, we did that. And after 3 months, there was no recurrence. Patient was completely, I think video, my resident has put, no, sorry. Yeah. So we did that, and the patient is happy walking now, but with a stick. I put him on non-weight bearing for 6 weeks in these cases, and the patient is okay. Everything came down normal, but he has a history of falling again. He had a small crack in the supracondylar 7 days back.
Perfect. Any suggestions?
One point regarding the trochanter, it remains unknown united, and invariably I see the wire breaks.
Yeah.
After a few months or years,
but still the patient doesn't have any problems, because most of the time, all of you must have seen trochanter, even if it is lying somewhere. The fibrous tissue and
fibrous tissue. Sorry, Dr. Sadhu, you're going to say.
I'm a bit of a pessimist. So with this kind of armament area, the iron work already there, I would take it as read that there is infection there somehow, and it may be dormant, and with your tinkering, it might flare up. So I would tell him that he could very well land up with a girdle stone.
Sure.
Just
But this
to-
is one case in which you should give prolonged antibiotics.
Yeah.
This one is a 6 weeks antibiotic,
6 weeks antibiotic.
irrespective of.
3 weeks I gave
origin.
injectable rather 6
Okay.
weeks.
So for all those who don't know, Dr. Sadhu's recently developed a big interest in Urdu poetry. Sorry, I'm finishing the session, but we can't let him go. He's actually now writing a lot of poetry as well. So maybe just before you get off the podium, if you can give us something, and the rest of the gentlemen can please
And
step
I would
down.
like to give my thanks to Dr. Sadhu because I learnt
I know.
32 years back. I
All
worked
of
with as
us.
a registrar and learned hip surgery
Chief,
from him.
एक कपलेट कहते हैं क्या कहते हैं मुझे क्या पता होगा
हाँ जी वो तो आसान है दिल टूटा हुआ है तो दिले नादा तुझे हुआ क्या है आखिर इस दर्द की दवा क्या है
Thank you so much, guys.
इसकी अगली लाइन है सर कि हमको उनसे है वफा की उम्मीद जो नहीं जानते वफा क्या है.
Okay,
Right,
so the
that's,
next session, the moderators are
yeah,
Dr.
Dr. Bedi, you have it, sir. All right. Dr. Bedi, can you mind?
Oh, yes, okay.
Yeah. May I call upon Dr. B.S. Murthy?
And thank you so much for very कैसे बिना ढूंढ के निकाल दिया, but well done. Well done.
Yeah. Dr. Samarth Mittal.
Oh, अच्छा तुझे दिया.
Dr. Pradeep Sharma. Sharad Agarwal. Dr. Pradeep Sharma. Dr. Sharad Agarwal.
Sharad.
Dr. Sharad. Dr. Sadhu. Dr. Pradeep Sharma. May I request you to give certificate to Dr. Ramneek Mahajan? अरे आपको Dr. Sadhu.
Sir.
अच्छा. Please.
You wanted long time back. When you allowed me to stand in that OT,
Dr.
when I
Ramneek.
came to Delhi, you were the first person who allowed me just to stand and come and visit him in his
Dr. Sadhu and Dr. Pradeep. बोलिए.
medical college where even the primary scrub is done by the postgraduate students, not by the GDL or the technicians. I came in, I was in Batra hospital. I did my primary, scrubbed the patient with a it was a trigger thumb. I still remember that was the first case in Delhi that I saw. He was supposed to operate that trigger thumb. I prepared, and he said to he came scrubbed. He said, "याद ही बड़ा है. Go scrub." I went, I scrubbed, I came back. Instant लगा ही नहीं था. ऐसे ये जब तक देखेगा नहीं कि वो दो डिजिटल नर्व कहाँ है, उस बच्चे को कैसे समझ आएगा कि ट्रिगर थंब में होता क्या है. So he waited for 5 minutes for me to come back, scrub, and then I saw that trigger thumb with 2 digital nerves.
Dr. Pradeep. Dr. Sadhu से बुलाना है. All right, moving on to the next session, revision concepts in THR. May I call upon Dr. Simon Thomas and Dr. Kshitij. Simon Thomas. Dr. Vivek, please, to moderate this session, please.
बड़ा मुश्किल है स्मार्ट लोगों के साथ मॉडरेट करना. Yeah, Dr. Mahesh will yes. I think good afternoon, everybody. Always a much awaited session usually. The problem is it comes at the end. But then that's how it is. We have some very eminent speakers who are going to talk to us. I think without further ado, we'll call Dr. Anup Jurani for his talk on ETO. He's already on the stage.
Why waste time?
Yeah, sir. That's so you, sir. That's so you.
All right, gentlemen. So let's go to the operating room to do this case. We're not seeing the video here. Yeah, I think I can if you allow me to do that. Yeah, I'll do 6 and 6 minutes. It's not playing. It's not moving forward. Oh, it is. Okay. So this is a protruded bipolar, as you can see, a cemented protruded bipolar. And you definitely need an extended trochanteric osteotomy, not only to remove the cement mantle, but also to take out this stem and the cup, because there is no way you can take it out because of the severe protrusio situation. That's the lateral view. You can see the cement plug down there and the protrusio of the bipolar. There is still a thin cancellous wall there. So though we're prepared for cage, but we'll show you how we did this reconstruction. But the key here is to discuss the principles of extended trochanteric osteotomy, which are much required in this case. These are Jude views, and they help you to analyze the defect in the socket. So the length of the ETO, the width of the ETO, depend on the length of the femur. So if it's a lady with a short femur, then you will need to plan your osteotomy accordingly. And if it's a tall male with a long femur, then you can make the osteotomy longer, but never less than 9 centimeters. So the osteotomy is usually 10 to 14 centimeters depending on the length of the femur. So you can see here that this stem usually is 130, 135. So your osteotomy is anywhere between 10 to 14 centimeters. That will remove the stem and the cement plug usually. And the width of the osteotomy is 1/3 of the femur, and you need to preserve your soft tissues. The essential thing is to have 4 to 8 centimeters of diaphyseal catch of the diaphyseal fixing stem. So those are the principles. The length of the osteotomy depends on the length of the femur. In our countries where the females are short, the osteotomy can be anywhere between 10 to 12 centimeters. Long, taller males can be longer. We need to take care of the stem length, the cement mantle, and the width of the femur. So the approach is posterior here, and you can see that there is always some fibrous tissue from the previous surgery. And you need to take off the G-max tendon and then start exposing after release of the external rotators. So that's the length of the osteotomy. You see I'm measuring. Here we are making the osteotomy about 13 to 14 centimeters long. The release of soft tissue and identification of the vastus lateralis, so important to get the interval right. Because of the fibrous tissue, you need to get the interval right, clearly delineate the vastus lateralis and the G medius. So that's very important to develop that plane between the vastus lateralis and the lateral intermuscular septum, so that you have a clean field of vastus lateralis, and you take a Hohmann and take the vastus lateralis anteriorly. So this is the posterior side, and then we pass a couple of wires distal to the osteotomy to prevent any propagation of the osteotomy fracture. So it's very important to pass a couple of wires distal to your planned osteotomy. Double circle wires or cables, whatever comes your way. We prefer double circle wires tightened with the AO tensioner. And then you take off the rest of the soft tissue from back of the femur after having taken the vastus lateralis anteriorly. That's marking the osteotomy. You can see very clearly, we're marking the osteotomy, the vastus lateralis and the G medius are anterior. Then you take a pencil tip Midas Rex burr. You take a pencil tip Midas Rex burr and start osteotomizing 1/3 of the femur. You can use a drill bit if you don't have access to Midas burr, but we have. So a pencil tip burr, sharp 1 or 2 millimeter burr, and make the osteotomy very clean without loss of bone. It's very important to preserve bone. And then you come distally and make the osteotomy corners round. So keep doing a semicircle on the distal part of the osteotomy and make a semicircle. Then use two 20 millimeter sharp osteotomes. 2 20 millimeter sharp osteotomes to open up the osteotomy anteriorly, while preserving the soft tissues, vastus lateralis and G medius. And ensure that your osteotomy does not propagate. So already there is a prophylactic wire, but the distal part of the osteotomy, which is semicircular by a Midas Rex burr, prevents the propagation of the osteotomy. There are some holes anteriorly as well, and then you make a clean opening of the osteotomy like that. And when the osteotomy opens, everything lies in front of you, and ensure that your G medius proximally there is intact. So G medius and vastus lateralis are absolutely intact. And then you have the whole femur in front of you, about 12 to 14 centimeters. Then change the burr to a thicker burr to remove that dense cement mantle, because if you use your osteotomes, you tend to lose out on bone. So, my time up? All right. So, use then osteotomes to remove the, I'll take 2 minutes more here and then decrease my talk on the dural mobility. So total time I'll take 12 minutes, 16 minutes only. Right, so remove the cement mantle with osteotomes carefully, and then remove the stem like that, and still the bipolar is not coming out because it's incarcerated deeply into the acetabular fibrous tissue. So be very gentle in removing the bipolar, and there you can see a protruded acetabulum socket, which will need impaction bone grafting. And it's very important to remove the distal cement mantle and see under C-arm that you have removed the cement mantle completely, because if you start preparing with some cement inside, you may actually perforate the cortex. So we always look under the C-arm. So it has to be under vision, because otherwise you will tend to perforate the cortex, which is very common situation in revisions. So removal of all cement, you can see 2 wires distally now, and those are prophylactic wires before you start thinking of reaming. And there you can see that we started reaming, and we checked under C-arm there. There you see we can check under C-arm that there is no remnant of any cement mantle inside or cement piece inside, which will misguide the reamers. And then the preparation of the socket with impaction bone grafting. And that's the socket, and a highly porous cup fixed well with 2 screws. That again checked under C-arm. And then finally the stem also. The stem diameter has to be checked under C-arm. The commonest mistake in revision situation is undersizing the stem, which will lead to stem subsidence. So it's very important to check the right diameter. It has to be scratch fit in the diaphyseal bone 4 to 6 centimeters. If you're using a modular stem, you need to close the osteotomy first, at least by a couple of wires, and then put the modular stem. If you're using the monoblock stem, it's okay to prepare the stem with the open osteotomy and then close it. So this is a redapt type of a stem. There you can see the osteotomy beautifully coming back, the stem nicely taking a rigid fixation in 4 to 6 centimeters of distal bone, and the osteotomy nicely coming back. That's a large head. The whole construct is very stable, and then you wire it back with 2 or 3 wires. So 2 wires distally initially, and 3 wires, double looped wires, nicely tied up over the osteotomy, which nicely closes back, provided you don't lose out any bone. Even if you do lose some bone and the osteotomy closes on 3 surfaces and not the posterior surface, it's all right, because it's cancellous bone, and you have preserved the soft tissue attachments, so the osteotomy union rate is 96 to 98%. So that's the final follow-up of this patient. You can see the osteotomy union, and the wires there, the offset restored, the center of hip restored. So ETO is a great adjunct, a great tool for revision situations, not only for removal of well-fixed stems and cement mantle, but also to take care of varus remodeling of the femur, and you can actually distalize the osteotomy to tighten up the abductor mass. So thank you very much. I don't know how much
Thank you, Anup. Can you continue with your next talk on dual mobility?
Yeah, I think I'll do that in 6 minutes.
Yeah.
And
thank you very much.
Yeah. Can you put on the next talk, please? How much time did I take? 8 minutes?
So we're not counting time.
All right.
Meanwhile, do you have any questions on this ETO? It's a wonderful video.
Yeah, so that's a great question. So whenever you're passing distal wires, be very careful that you are next to the bone. So you clear the periosteum, otherwise you may actually, there are cases where you take the profunda femoris if you pass your wire passer in the soft tissue. So be very careful, you're next to the bone, and then use a periosteum to make a window there, and then pass your larger wire, AO wire passer, and then very carefully so be very careful of the profunda which passes close to the bone in the middle third of the femur.
And a very maybe a stupid question to sound.
No questions are stupid.
So
no.
ETO means trochanteric osteotomy. We want to open up the femur.
That's right.
So why only posterior approach? Can we just take out any 1/3 of the circumference and do it?
No, actually you need to, you can do it by the lateral approach. That's also well described. But what you need to do is any approach, you need to keep the G medius and the vastus lateralis intact, because that vascularity is going to encourage union of the osteotomy. That's the key. Approach is irrespective.
Anup, would you be bothered if you cannot close the osteotomy absolutely after the full wiring?
No, so that's a very common situation, Vivek, with modular stems, because when you use modular stems, the proximal part is thicker. So it's all right. As I said, if you can oppose 3 surfaces of the osteotomy and not the posterior surface, it's fine. Yeah. You may have a 3-4 millimeter gap there, but the osteotomy is ultimately going to heal if their vascularity is good.
Yeah, so the key is, as long as the soft tissues are intact, there's hardly anything to bother about non-union. Can you go ahead with the next talk, please?
Can you put on the timer, please, so that I can see? Okay. So dual mobility understanding as we stand in 2023. So whenever we are looking at any articulation, the best is to look at the registry data. Registry data is not good for success stories, but it's very good to when you're looking at failure at mid to long term. So we asked this question when we were researching for this particular talk. We asked this question, do dual mobilities cup reduce revision risk in femoral neck fractures? And this was an excellent study we got. This is a Vivek meta-analysis from 6 arthroplasty registries. And the main question was, does it make any difference in revision risk or dislocation risk when you're comparing with a conventional total hip replacement? And you'll be surprised at the answer. The answer from these 6 registries at mid to long term is that it did not have a revision benefit for dual mobility when compared with conventional THA in fractured neck of femur patients. That's really surprising. But that's the story, because in order of descending frequency, the most common indications for revision of dual mobility were infection, dislocations, intraprosthetic dislocations, fracture and loosening. And at the end of the slide, you can see total revisions were nearly the same in large thousands of cases of these combined registry data. So these are some of our indications for dual mobility, and we use them for very selected indications. So these are high-risk cases. This patient, 85-year patient with Alzheimer's, so neuromuscular issues or cognitive issues are best cases for using dual mobility cemented in this situation. This is a case, neck of femur in a polio patient. So when you have a polio patient, the musculature, there is compromised musculature, especially the abductor, and there is high risk of dislocation of these patients. And this is also a good case to use dual mobility. Neck of femur fracture with Parkinson's disease. So these patients generally lie moribund at home and they are neglected, and the fracture was missed. And this patient had very severe Parkinson's disease. Again, a good case for a dual mobility. Now, dual mobility is also a great option when in elderly you have dislocating bipolars. So the stem is okay, but the bipolar is dislocating. So it's very good to restrain these cups by using a dual mobility socket. Okay, failed DHS. Again, failed DHS situations.
reabsorbed head, greater trochanter, non-union, very good case for a dual mobility because you can restrain it and not bother too much about abductors, which are difficult to unite in these osteoporotic patients. Failed PFN situations, very common in our country with flying off of GT, and the union of GT can be very difficult to achieve because of osteoporosis. So these are also good cases to use dual mobility, restraining and preventing dislocations. Now this is a rare case, heterotropic ossification with loss of abductor mass. So abductors are all ossified, and when you start removing all the ossification, and you are not left with any abductors. So without abductors, it's very difficult to achieve stability, and this is also a good case to use dual mobility. Revision situations, this was a case where the hip was dislocating post-acetabular fracture. The cup was well integrated. This was 4 or 5 years down the line, and the stem was also well integrated. And what we did there was we cemented in a dual mobility. You can see that the cup orientation is all right. The abductor mass is also all right, but still the hip is dislocating. So with a well-integrated cup, we cemented in the dual mobility. You can see that we have cemented in the dual mobility and achieved stability. So these are some of the things that you can do to achieve stability in such situations. Now, dual mobility has got us a different set of complications that we need to be very well aware of. They are called intraprosthetic dislocations, where either the head can dislocate from the poly or the poly can dislocate with the head together. So there are two sets of complications which you need to identify. And when you're trying to reduce a dual mobility, you have to be very careful because the poly can actually go out and the head can reduce. So the poly still remains out and the head can reduce, like this situation where the head is reduced but you will have an eccentric reduction because the poly is still out, and that's called a bubble sign. So bubble sign means that the poly is still out, which will come as a bubble in the X-ray if you look carefully, or you can take a CT scan. Let me share with you our worst complication with a dual mobility. This was a 75-year-old patient with history of bilateral total knee. And this patient had an intertrochanteric fracture, severely comminuted, and it was failed fixation. And then we did a long stem total hip with a large head. The patient started dislocating because I had done the surgery. I knew that the version of the cup, as you can see in this case also, and the version of the stem was all right. The abductors were compromised. The abductors were just not uniting. So we revised it to a dual mobility. But the patient started dislocating with a dual mobility. So we went back again and took out this impinging piece of bone there, and still, so you can see the GT will not unite. So we wired it, and we even thought of plating the GT, but the GT was all fibrotic and would not unite. So in spite of the dual mobility, the patient was kept on dislocating, and finally we had to restrain it by using a constrained liner. So this was our worst complication of dual mobility. So please remember, dual mobility is not a panacea, is not a wonderful situation to prevent instability. You got to get your cup version, your stem version absolutely correct, and your leg length and offset correct to prevent dislocation. So dual mobilities can also dislocate, and you got to be very careful of intraprosthetic dislocation. Identify it very carefully, otherwise you will have bigger issues on your head. Dual mobility is increasing. So this is again registry data to show that dual mobility use is increasing in all countries, including ours. But then we asked ourselves the final question: is the re-revision risk for dislocation and aseptic causes greater with dual mobility constructs? So are dual mobilities truly better in revision situations? They seem to be. In all registry data, they seem to be doing slightly better than larger heads. So you can see that dual mobility, the green line, and the head size 36 is the blue line, and the green line is below the blue line. That means that the revision risk at 10 to 15 years is lesser with dual mobility in revision situations. So in revision, it seems to be doing better. So this is the summary of dual mobility sockets as we stand in 2023. Should be used in elderly with poor cognitive function and neuromuscular issues, does not compensate for improper version and offset. It does not seem to reduce the overall risk in neck of femur patients, has value in revision situations, especially with abductor deficiency, but it has also brought a new set of challenges of intraprosthetic dislocations, which we need to be identified very carefully on skeletal x-rays and managed properly. Thank you very much.
Thank you, Anup. That was very comprehensive. Anup, you can sit here, please. Can I invite the next speaker, Dr. Narayan Hulse, to deliver his talk on bone defects on the acetabulum side. Meanwhile, are there any questions on dual mobility? I think we can start, yeah.
At the outset, thank Ramnik and all the organizers for having me here and for great arrangements, including the live surgeries yesterday and today. Topic is on acetabular reconstruction, especially on the acetabular defect, which is, of course, is one of the nightmares for the revision surgeons. So what is the purpose of this reconstruction is basically an intimate contact between the bone and the acetabulum so that the mechanical stability is obtained and the bone ingrowth happens inside this acetabular cup. That also should distribute a reasonable uniform stress on the acetabulum so that the bone above the acetabulum will remain healthy. And also we should achieve an optimum cup orientation so that we can get a reasonable stability to prevent dislocation. So there are mainly two classifications. One is a AOS classification, which is common, a very easy descriptive classification, but it is not that kind of a prognostic. Segmental, cavitary, combined, pelvic discontinuity, and arthrodesis. However, the Paprosky is more popular and it helps us in terms of both classification as well as prognosticating them and also plan for the treatment. So it considers 4 points. One is the superior migration, ischial osteolysis, and osteolysis of the teardrop, and the position of the cup relative to the Kohler's line. 1, 2, and 3, and 2 and 3 has subgroups ABC and AB. This is the type 1, which is like a little localized osteolysis inside. It is like a normal situation. You may need a little larger cup, otherwise the normal cup can accommodate in these kind of defects where there is a localized osteolysis. Whereas in type 2, you have type 2A, 2B, and 2C. The problem here is in 2A, the rim is still intact, but we have got a larger cavity, almost like a cavitary defect. Second is a segmental type of defect where the rim is absent superiorly, whereas in 2C, you have medial defect as well. So you may have to have a larger jumbo kind of hemispherical cup or a bone graft if needed in some of these cases. Whereas in type 3, we have 3A and 3C. In 3A, you have superior and medial defect. The rim is absent superiorly. You can see that like a segmental and the medial combined defect. Whereas in 3C, the columns are involved as well. There is no intrinsic stability. And that's why we have a problem with no columnar support in type 3C, which also include pelvic discontinuity. So whereas in 3A, we may have to use jumbo cup, 7 graft, which was just been mentioned by somebody, metal augments. Sometimes we may have to accept a high hip center, cage or a plate, triflange, or sometime you may have to get a CT scan done, a custom printing, etc. in difficult cases, which may be useful in 3C types. So the bone grafts commonly used are ideal for smaller bone defects. More than 50% bone loss may need a cage rather than just a bone graft. You need to know that the bone grafts have a poor incorporation and late failure, and that leads to the failure of our construct. For example, this gentleman is a primary situation, but you can see a double acetabulum on the left side, a huge defect superiorly. Intraoperative photograph, you can see that dual 2 acetabulum, superior and inferior large gap, which is filled with his own bone graft, femoral head bone graft with a couple of screws. That's an immediate post-op on 2016 and 17. And now you can see that the acetabular superior graft is completely incorporated. Sometimes, this graft may incorporate in those simple situations, which sometimes we think the graft may not even be required. So you can't rely much on this graft, but some of them can be useful in younger people to restore the bone strength. So the hemispherical cup have been the mainstay of treatment, most commonly used. These cups address most revision problems. Initial stability is provided by the press fit. You can also address the gaps behind the cup with some kind of bone graft, which can be impaction or a morcellite bone graft, or in fact structural. 1, 2A, 2B are the indications, can be combined with the augments as well, and 95% survival at 20 years have been shown in some studies. Jumbo cups, there is nothing like jumbo cup, they are just larger cups, usually above 60. Survival rates 92% at 14 years. For example, failed this resurfacing managed with a jumbo cup without anything else. Impaction grafting, great success shown in European countries, not much in North America, difficult technically, but it can restore bone stock, as I was mentioning earlier. For example, this gentleman, I operated in 2012. This was a Freeman type of hip replacement done by none other than Dr. Mohandas in Chennai. After 20 years or so, this got lysis and managed with an impaction grafting. Now it's about 12 years follow-up, doing well. Another infection situation, 2-stage revision, impaction grafting. You can see the follow-up X-ray of the acetabulum showing reasonably good position after 3 years. Anti-protrusive cage, they are the necessity, especially in type 2C and type 3. The main problem with them is that they provide a contact area, but they never have a biological fixation. That's why they tend to fail, they tend to break. This situation, again, a bipolar revised to a cemented hip about 15 years ago, loosened, infected, 2-stage revision again with a cup. The anti-protrusive cage, you can see that this is about 7 or 8 years now, doing well. Another similar situation, cage, 4 or 5 years follow-up, cage, bone graft, and then we have the mesh behind for the bone graft. That was the pre-op, and you can see the post-op after 5 or 6 years. These porous metals have been very useful adjunct because they help us to build both superiorly and if needed in any position. 2006 THR, revised in 2017, dislocated immediately, and then patient was referred to us. That is the augment superiorly. Now it's about 4 or 5 years follow-up. The last one is the pelvic discontinuity, difficult. It can be an acute discontinuity or an old discontinuity. Acute discontinuity, probably we should fix it, and the old one we have to augment it. So this is a radiation-induced AVN. Uncemented hip was done originally. Slowly the posterior column was broken with a progressive osteonecrosis due to radiation. A posterior column plate, augment. Similarly, for a fractured neck femur, this is how the patient was presented to us. This is the story of this patient, fractured hip. THR was done not primarily after 3-4 months. And this is the situation. You can see the initial fixation itself was not great. We did an angiogram to rule out any vascular associated issues. Posterior column plating, allograft. This is just about 5 months now. It looks like a good amount of bone support and the cup remained in good position. The last patient done about 20 years ago, none other than famous Dolokia and his team. And you can see the acetabular cup has worked for about, I think, 18 or 20 years. We removed that and did a biological fixation this time. And that's the patient's journey of, the walker to stick and not stick and doing well. Thank you very much.
Thank you.
Thank you, Narayan. Can I invite Dr. Yatinder Kharbanda to deliver his talk on instability in total hip replacements?
Thank you, Chairman sirs, and good afternoon. So I will be talking on how to, prevent instability rather than, much on what to do after instability. These are the disclosures. So many times we come across our own patients done reasonably okay with the reconstruction of acetabulum and orientation, proper orientation, but comes to us and we miss a heartbeat, dislocation. Most of these are fresh dislocation within the first 3 weeks, and these can easily be managed by manipulation. They generally don't require if all the other things are correct. So dislocation or instability is the most common diagnosis now, resulting in a revision total hip, and the cost again are high of treatment. There is a lot of variation in reported incidence of dislocation, but a comprehensive report in 1992 suggested 2.25% dislocations in primary total hip. However, with the recent techniques, it has gone beyond. It has gone less than 1%. Timing, as I said, most of the dislocation, more than half the dislocation occurs in the first 3 months post-op, but they are generally due to weak muscles or some wrong postures, as long as the other things are okay. And more than 3/4 are in the first year. And we all know the risk factors. I'm not going to elaborate, but I'll talk something on distorted acetabulum and deficient abductor mechanism. Fracture neck femur already Anup has covered. These are few of the surgeons and prosthesis specific risk factors. So fracture, it has already been covered, and I will speak to Anup about the incidence of dislocation later on. So generally, if you have patients who have neuromuscular disorders, initially I used to do a constrained hip because dual mobility was not available. But today, like in a 25-year-old autistic child, I would do a dual mobility to prevent dislocations. Surgical risk factors. Approach is again a controversial thing, but it has been seen in registries that, in the registries that posterior approach has the maximum chances of dislocation. Anterior, the direct anterior approach has the least chances. But if you do a good posterior capsular repair, the chances can be reduced less than 1%. And this was the report from Pelisi where he showed dislocation rates reduced from 4.1% to almost 0% at 1 year follow-up. The next important thing is orientation, the component orientation. So there are 3 things. One is the position and the alignment, and last is the orientation. Always medialize the socket as much as you can. Cup position has been talked about. I tend to generally put in the correct center of rotation. However, up to 1 centimeter of superior migration is allowed. This is an illustration case 1 where this patient had some bullet injury, something, fractures, and presented to us like this. He was operated once or twice. You can see 1 screw there. And unfortunately, the cup has been positioned, the center of rotation is much higher, and it is also lateralized. So this is bound to fail. Surely enough, it came up with dislocation in 3 months' time. It was reduced, and then again it came up in 4 years' time with complete disruption of the cup as well as dislocation. So this was revised, and a proper orientation as well as the cup positioning has been achieved. Position, that is the alignment of the cup, that's a big factor. We all know the safe zone, but many times even the outliers are okay, and sometimes even the safe zone we find dislocation because there are other factors. So generally, abduction of 40 to 45 degrees, and that is the cup abduction. Acetabular anteversion is put 15 to 20 degrees. Femoral anteversion is 0 to 15 degrees. How to get the cup orientation right? generally, these are the three things: anatomy, that is, you see the posterior wall, anterior wall, superior wall, and the inferior wall. You have various guides, and the most important thing is TAL. It is, we don't have the anatomy. When we don't have the anatomy, then we have real problems, but we can have the other guides, that is the TAL or our positioning. So this was a patient who had 3 months old unreduced fracture dislocation. You do CT scans. In these cases, many times doing a 3D printing gives you a good benefit of trying out what you would do preoperatively. This was how it was reconstructed with the plating of the anterior column and bone grafting. I think here we did not have to use any augments. One should also remember the influence of the pelvic tilt on anteversion angle, which has been talked in the morning. Now I want to emphasize the role of TAL. This is TAL is patient-specific reference point. It is you don't have to think about the position. You don't have to think about other things, and it is identifiable in most of the cases. Dislocation rate, if you do with this, has been reported as less than 0.6%. In conclusion, TAL in determining the anteversion has led to a reduction in the rate of dislocation, and advantage of this landmark is that it's independent of the position of the patient. So whenever you do any by a posterior approach, position should be very stable. The surgeon himself or herself should determine the position. Acetabulum should be exposed properly with the anterior, posterior, as well as the superior and the inferior walls. And you can have the other guides to determine your positioning. Combined anteversion has been talked about, and it has been seen that you should try to have a combined anteversion of 45 degrees in females and 20 to 25 degrees in males. Impingement should be taken care of, which has been said in the previous lectures. Any bone or cement or should be removed. Any wall overhanging should be removed. Soft tissue tension again is an important thing, and this is what I want to say about the trochanteric and the abductor, abductor muscle power, where sometimes dual mobility may have to be used. This is an example of totally a wrong femoral version which was done. Obviously it dislocated, and this had to be revised with cement in cement revision. So this is an example of abductor or the trochanteric not being taken care of well. This was a lady with a rheumatoid lady with the fracture and bad arthritis. Total hip was done, but however the abductors, the trochanter seemed stable, but and therefore the plate was removed. It dislocated in 3 months' time, and it had to be fixed. The trochanter had to be fixed well and reduced well. Approaches, as I've said, anterior approach has a minimum dislocation rate, posterior approach has the highest dislocation rate. Femoral head size 36 has been shown to be in the registry to have least dislocation rate in all approaches, and dual mobility cups are being increasingly used. Anup has very well demonstrated in what all cases it should be used. Surely in revision as well as the primary, it has we have seen increased use in DMC. This is a case where trochanteric fractures, trochanteric fracture did not heal, did a total hip, but this was not a dual mobility, it was a normal hip. It dislocated. So here I would like to emphasize that such cases there is a place of dual mobility cups. So in conclusion, orientation is important of the cup. Offset and adequate soft tissue tension should be achieved. Adequate posterior release, posterior repair if you are doing by posterior approach, and one should preoperatively identify high-risk patients, and counseling should be done. after doing all this, I still don't understand why this hip didn't dislocate. This patient has been going on for 10 years with this hip. And so it's sometimes it's been said that what really works for the hip, we still don't know, but there are a lot of factors which we have to take into account. Thank you very much.
Thank you, Dr. Yatinder. Can I invite Dr. Vikram Jain to deliver his talk on spacers in revision hip replacement?
Good afternoon. So it's a relatively simpler topic, and I would like to kind of cover it with the help of one case. Young adult, neck femur, seen outside, operated outside, very young, at 30 years of age, he got a bipolar done, and post-operatively they diagnosed him as a case of diabetes, got infected very early, he had a discharging sinus and 4 centimeter of shortening. That was the kind of position he presented to us. The stem had sunk in, the trochanter was high riding and impinging, and he was in acute pain, not able to mobilize. So management of a periprostatic infection is obviously difficult with no fixed protocols. You can manage an acute infection with antibiotic coverage, but there's no enough literature. But you can always debride and do a liner change, but that is only helpful in acute stages. In hip, you can do a resection arthroplasty, a 1-stage revision and 2-stage revision. 2-stage revision being the gold standard and gives you the best chance of clearing the infection and getting a hip back. So 2-stage revision, the classical approach is to do an aggressive debridement, remove everything, including the cement, put an antibiotic cement spacer in, and make sure that you are able to grow a bug and use those antibiotics intra-op and give them 6 weeks of post-op antibiotics, preferably IV, but mostly it's not possible, but IV and oral. Then 2 weeks of drug holiday, and then they get a 2nd stage of final reimplantation of the implant. So what kind of spacers that you can use? So very commonly it's used cement as a spacer. It's just you make a ball and put it in the acetabular. And you can make a cement spacer by using a mold so that it resembles a prosthesis and keep it in. And sometimes you can implant a new hip with a cement spacer as a spacer, which is called as a Kumars. So just to have a look, so you can do you can bend a K-wire and make a cemented spacer. You can even use a smaller stem and mold it, cement around it, or you can actually reimplant the prosthesis, new prosthesis with antibiotics put into the cement. Simplest example is something like this, where you put a cement spacer, just a ball of cement in the acetabulum after thorough debridement. The second case is where ETO was required to clear the previous cement. You can do this mold thing. This mold is now available out of in India also. Earlier it was to be very expensive. We did use it. The problem is that the neck is very small in this particular mold, and the patient, the idea is actually to keep the length of the soft tissue intact and maybe give him some mobility with crutches. But this neck broke because it's of cement. It broke within the week, and then eventually he had a stage 2 revision. You can implant a stem loosely coated with cement and put it back in and allow the patient mobility for 4 to 6 weeks before you go back in. So coming back to the original case, this was short, painful hip, and with diabetes and very young. Excision arthroplasty did discuss with him because he had money issues at that time. You can remove the implant and put on a cement spacer, but the problem with cement spacer regular that is used is that further shortening will happen, and then he's already very short, and diabetes obviously needs to be controlled. So the benefit of spacer is that there's an antibiotic that is delivered from the cement, and the soft tissue lengths are maintained, and patient has some limited mobility, and then finally when they have their second final stage, you are able to restore the length of the limb. So what did we do? So there are enough evidence that you can actually implant a prosthesis with cement, loosely cementing so that it does not interdigitate in the cancellous bone. This allows patient mobility, still get the drugs delivered, and then do a second stage. Enough literature evidence that this works. So this was done for that patient. The previous prosthesis was removed. An Indian cheap cemented stem and a cemented cup was implanted. He was Staph aureus, MRSA, so Venco was mixed, 4 grams in the cement both sides. But the problem was he was so short that after sinking the stem and attempting reduction, he was so short and so tight that the reduction was extremely difficult. We did manage to reduce it, but he ended up reducing itself in 30-40 degree of flexion at the hip. He was closed like this, brought out, put it on pillows, and then given traction to kind of stretch him out. The idea being that you loosely cement, put a larger size cup, 36 head, and then mobilize this patient. So this is what happened to this patient. After 2-3 months of follow-up, he gradually straightened his hip, his flexion deformity improved. He had money issues, and then he stopped seeing us, and he started walking again, and he had reasonable good function and overall happy with his quality of life. But we didn't see him till about 5 years follow-up. So this, I was in a different city, and this guy on a intermediate prosthesis was still walking without failure. And this was such loosely cemented by me only, which is so wonderful to see. Now I was in a dilemma because he remembered 5 years had passed, and I was after him to get it revised. And he said, why do you want to give me a revision? Because I am doing perfectly okay, except for maybe some amount of shortening that was still present. But I did tell him that you can further increase your quality of life by regaining the length. And so he took my word, came back after another 6 months to finally agree to a revision. So when we went in, the cement was not interdigitated. It just came out. It's so wonderful. But I don't know why he survived for 5 years, because he should have loosened and bone quality would have, but it came out, so did the acetabular cement, and he had no signs of infection. So he ended up doing a Wagner kind of revision on a hip. We were able to restore his leg length, and he's doing well. But he's very young, so I expect him to fail again. Thank you.
Thank you, Dr. Vikram. Now, before the next talk, can I request the X-rays of Anoop's yesterday's surgery, post-op X-rays, to be displayed here? Audiovisual guys, please. Yeah, meanwhile, I will invite Dr. Himanshu to be there for his next talk on periprosthetic fractures.
I thank Ramnik and his team for inviting for this platform. I think the session is quite silent, and there is hardly any interaction from the delegates. So my topic is fractures, so I think that will energize people. So we can discuss their cases. I am not just advocating theory. Okay, just first, after the X-ray we can...
Yeah, after the X-ray.
No, I want to show the X-rays. Na? So, sorry to interfere in between, but I have to leave, so just give me 2 minutes to... Yeah, go on to the next slide, please. So, kinematic alignment is about reproducing the 3 kinematic axes. So, you can see those center in the lateral X-ray, where the center of the femur is in the lateral X-ray. That's the kinematic axis that we're trying to reproduce by cutting equal distal medial, distal lateral, and posterior medial, posterior lateral. Next slide, please. So, these are the MDFA and MPTA that we drew, and we try and reproduce with the help of any robotic instrumentation. You can do it with manual as well, but the key is to reproduce these angles, and a normal HK of that patient on that side is 177. That's 3 degrees of varus as compared to 9 degrees of varus here. So we'll aim is to reproduce that side. Next, please. Yeah, next, please. Okay, so these are some of the figures that you saw yesterday.
But the important thing is to get full extension of the limb at the end of the surgery, not 3-4 degrees, but 0 or 1 degrees. Next. 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 Go on to the last slide. That's the X-ray. No, the X-ray. Now, this is the X-ray that we'd like to analyze. You can see the tibia is in varus. Now, the tibia is in 3-degree varus, and there should be no fear that this tibia is going to fail. The reason is that you are restoring the MPTA and the MDFA of that particular patient to 2-degree valgus on the femur and 3-degree varus on the femur, thus restoring the overall HKA still to 2 to 3-degree varus. And because there is no soft tissue release at all, you're not touching the medial side at all, and restoring the slope and the flexion of the femoral component along with restoring the flexion kinematics, this knee is going to last as good. So the main fear in orthopedic surgeon's mind is how you can keep your tibia and varus. But that's the normal anatomy of this particular patient. And this is the way the kinematic alignment X-ray should actually look like. The Knee Society does not give any guidelines yet, but when it will, this is the way kinematic alignment X-ray should look like. Thank you very much. If you have any criticisms or any critique, I'd like to welcome that.
Yeah.
Yeah. Can you go back to the last slide, please?
I gave 3 degrees of varus. But then I realized I have to put a stem. So then the stem will hit the cortex. So that is something we should be careful. If you have got a complex knee and you feel you are going to use a stem, better go for a mechanical.
I agree completely, because as soon as you put a stem, the stem will dictate the position of the component.
Exactly.
So then it's not a case for kinematic alignment. Absolutely, I completely agree. Thank you very much.
Thank you, Anu.
Yeah, thank you.
Yeah, Himanshu, can you carry on with your next talk?
My topic is periprosthetic fractures. So I will not, just a small thing on the classification. The Vancouver classification is the most widely used for these fractures, and it has a widely accepted due to significant intra and inter-observer reliability, and it also guides the therapeutic treatment. So this was later, the 3 more categories were added by Duncan et al., like D category, D, E, and F, that dividing the bone between, that the fracture is dividing the bone between the 2 implants, and the fracture is involving both the 2 bones of the prosthesis, and F is the facing and articulating the hemiarthroplasty. Now we'll go to the cases. You should know all, you are all versant with the AO principles. So this is a 74-year-old female with history of fall at home. So you should leave it, you will leave it like that. You will do something for it, some wiring, some plating, like chairpersons, like Dr. Lavani.
Yeah.
What will you do for this kind of a fracture? Just
That
a
depends
GT
on-
avulsion. It's a type A fracture as per the Vancouver.
I think if the rest of the implant is stable, I would assess the hip stability. If it is fine, I think I would allow some non-weight bearing for some time and then leave it.
See, that
Okay,
also
anybody
depends on
for
what kind
fixation of this fracture?
I would actually want to see what kind of stem this is. This, I think, is a proximally coated stem, and
Yeah.
So I would be actually worried about, because this is such a big chunk, that I'll be actually worried for the implant becoming unstable over a period of time. Had this been a fully coated, a Corel kind of stem, I may actually have wanted to wait for some more time.
So considering that it's a considerable chunk, so we fixed it with a plate. This is a Philos plate. So you have to innovate, and a cable was also used, and this is a 3 months follow-up, and patient is doing fine. So I will move to the next case. This is a case was given to me by
Now
Dr.
that you asked one question to us, I think if you go back to that slide, the trochanter gives you enough bone mass that you don't have to, you can get a 4.5 screws top to bottom. Secondly, you can always have enough space in front of that stem and behind to have a bicortical purchase also,
Sir,
which you have already done.
Usually, see, This Philos gives you an opportunity to give divergent screws and some cross screws also. So that gives you more fixation, and we have supplemented with a cable also. So that gives a decent fixation, and distally we have used only 2 unicortical screws because these are female patients. Usually sometimes the bone stock is not that much that you can put 4.5 mm screws.
When you opened it up, was the hip otherwise stable? Was the
hip otherwise
what
stable.
was the condition of the distal portion of the?
The stem was well fixed. There was no movement, and the hip was stable. So that's why we proceeded for the fixation.
All right.
So this is not my case. This is given to me by Professor Kolchowski. This is a valgus knee, and there is a notching, grade 2 to 3 degree notching. So this proceeded 7 months post had a fracture. So can anybody, this is a basically B1 if we classify it by Vancouver classification. So a MIPO was done, and you can see that on the lateral view it is not reduced. So anybody for revision of this fixation?
I think
we should accept that.
I think that's for to trauma principle. Sometimes when we come out of the X-ray, it's not exactly best of looking. But we sometimes hope and watch.
As long as the soft tissues are preserved, I think it's better to accept it.
So it remodeled, united at 1 year.
A large surface area.
Yes.
It helped you.
Spiral fracture, long spiral fracture. So no theory. A rheumatoid patient, a supracondyle fracture. This is the most common fracture involving a total knee replacement. So rheumatoid is a risk factor for getting a periprosthetic fracture. So anybody for nailing in this kind of case?
This implant won't take a nail actually. This is a Zimmer implant. It does not have the box big enough to take a supracondylar nail.
So when we can use a nail and when we should use a plate?
I think with the advent of good fixation methods with the multiple screw options on the plates, plating has become by and large a standard for distal femoral periprosthetic fractures, because introducing a nail through the box all the time, it's a challenge, and once you introduce it, you end up flexing the distal femoral component with respect to the proximal, and it really doesn't work.
Okay, so...
Yeah, sure.
These are rheumatoid patients. Wherever the plate ends, they have another fracture. And I think latest evidence shows that the nail is a superior construct than a plate. It is any days biomechanically more superior. And I don't agree with Dr. Simon as well. Almost every knee in the market, whether it is a PS or a CR, accepts a nail. And there are ways to do a nail even if a box doesn't accept a nail.
Yeah, so there are certainly. But if you put a long spanning plate, follow the correct biomechanical principles, generally that fracture does not happen. Yeah.
I don't think really. I will state that.
Yes, Ramnik, you wanted to make a comment. It's okay. It's okay. But with the post on, several times, yes.
Every knee will take a nail, yes. And the thing is, a nail is always a better option because it accepts load bearing early. And nowadays with nail and a plate combination is probably more preferable than a plate alone.
I would give a clinical situation wherein the knee doesn't flex more than 40 degrees.
So the best idea is always, if you have a periprosthetic fracture which you need to fix, which is fixable, it will get a nail and a plate, so that the patient can be allowed to immediate start weight bearing. And I would probably let Dr. Sarvan.
Yeah, Dr. Kamala, please.
I think what he said is nail alone would not be helpful. It is high rates of failure. Nail and a plate or a dual plate today in a rheumatoid.
Agreed. So, a lateral plate was done, and 3.5 mm lag screws was used, and she lives in Almora, and she never came for follow-up, and this is the picture she sent on the WhatsApp. She's walking, and she lives alone there. This is another patient, 61 years old female, had a bipolar in 2012, a cemented one, had a fall at home, and presented with pain and inability to walk. osteoporosis, rheumatoid, hypothyroid. So there is a periprosthetic fracture. So it was revised, it was not revised by us, but because it was our patient, it was revised at some hospital in Delhi. So fully coated this solution stem was done. So over the period of years from 2013 to 18, this gradually started moving in, and we have seen Dr. Jurani has also shown this X-ray. Just one more case, and it was revised because we advised her revision, and this was revised in Bombay, and a cup and cage construct was done. And the stem was retained. They said that the stem is stable. And patient is ambulatory with the help of a walker. And these bipolars in soft bone, they can immediately migrate. So, and they are challenging situations to revise. This is my last case. I will not take much time. This is a uni compartment, well functioning. Rickshaw hit this lady from behind. And there is a fracture of the medial tibial condyle. And the component position has totally moved. So what armamentarians you will keep in the OT, and you will go with a normal implant, or you will have some CCK kind of a prosthesis?
I think this is a fairly common scenario to see. On table, after removal of the implant, we must keep some wedge kind of a thing ready and a tibial stem ready. I think we should be able to get away with the non-constrained overall implant, but keeping a varus valgus constraint is always a good thing to have.
So a normal PS knee was done, but the bone just below that area where that you can see there is a mesh with some 2 screws. It was quite soft bone. So to supplement that, because it has a low profile, so we fixed it with the bone, and this is a 9 months follow-up. And there I end my talk. I will not take more time.
Thank you, Himanshu. And now, last but not the least, we have Dr. Gurinder Bedi with us. May I invite you for your talk on DVT prophylaxis.
Okay, this is one of those somebody's got to do it kind of a talk. So, I mean, you guys really got to bear with me on this one. Can I have my presentation, please? Okay. So we're talking about something which we normally don't talk about in open houses. It's more a closed kind. Sorry. Oh, sorry. Okay. Okay, so this is what we want to talk about. So there's no doubt about it. There's nothing spoils a good operation than a long follow-up. I think that's what Dr. Mani always used to keep saying. The two other things that seem to make a difference is, one is if the case gets infected, and the last one is if the patient is no more there to give you a long follow-up. So this is something related to this, which can actually, even your best of surgeries can sometimes fail, related to some of the complications which can occur, which you never really thought about. So here's what we agree with it. There is zero denying the fact that all operations carry a risk of thrombosis. Some operations have a high risk, some have slightly lower risk. Most thrombosis which will happen will resolve spontaneously. But the commonest cause of a pulmonary embolism, however, is a venous thrombosis. And we know that pulmonary embolism is a fatal condition. We're familiar with Werco's triad about why an operation is likely to give you a higher chance of a problem. In fact, all three things, the triad actually goes together, and we know why it all goes together. We know why arthroplasty has got bigger issues which happen. There will be other risk factors which happen, something related to the patient's own milieu. The patient might have some high predisposition, and again some surgeries being more immobile. So major orthopedic surgery carries a high risk, somewhere in the vicinity of what, 40 to 60%, whether you're doing a hip replacement or a knee replacement, trauma again, and any pelvic acetabular fracture surgeon will tell you huge risk, spinal cord injuries, huge risk. So this is the cumulative incidence of thromboembolism after arthroplasty. We know that the rate of VT after knee replacement is more than the rate after hip replacement. Again, lots and lots of studies pretty much say the same thing. This is Warwick's work that I'm talking about. So we all agree that arthroplasty is a high risk, and we all understood that if you do a prophylaxis, you reduce the incidence of get a venous thrombosis. So this is what happens when you actually reduce the risk. So the incidence drops down by at least 50 to 60% compared to what it was. The pulmonary embolism also seems to go down. This is slightly difficult, but we'll talk more about it in the near future. So with thromboprophylaxis, the rate of symptomatic, remember I'm not saying venography, can be reduced to about 1 to 2%. So the thing to note about this is the incidence of thromboembolism after hip replacement and knee replacement actually persists for a very, very long time, somewhere in excess of about 30 to 60 days around. Follow the second line, the blue line, which you can actually see what prophylaxis does. So we also understand that distal DVTs, which is commonly quoted in the literature, are the ones which are normally innocuous and you will not have a huge problem. That is why the chance of getting a symptomatic issue is much less, because most of them are below the knee. Proximal ones, however, are very much more dangerous because there's a higher chance of a complication. So pelvic fractures go up very, very high, essentially because the chances of getting a pelvic vein thrombosis is so high. Knees have a much more higher chance, as we said, but we worry less about them because most of them are very, very distal. So here's what we continue to know. We know that the consequences, you can have patients presenting with pain, swelling, embolism acutely, or even a compartment syndrome. What we don't talk much about is the post-thrombotic syndrome, which is you can have a continuous element of swelling, which the patient keeps on coming back. You can have a pigmentation of the skin. You can have eczemas developing because of the iron, which actually transsudates from the vessel into the skin, gets deposited in the lining of the skin in the calf kind of an area. Then you can have recurrent venous thromboembolism, and you can actually have even venous ulcers developing. Most thromboembolism episodes will be detected very, very late. Most pulmonary embolisms will be silent. So what you see is a small percentage of what really happens. So this is the reason why you actually get a problem, and the problem really comes from, it comes from the fact that your deep vein is getting blocked. The blood still has to go back, and the only way it can go back is if the superficial vessels take that blood back to the heart, and the way it does it is the perforators open up, so a one-way flow of blood actually stops, and the blood goes into the superficial veins, and the superficial veins are then dilated and gorged with the blood, which should normally have gone up through the deep veins. So when this happens, you start getting this thrombosis and everything. So this is a man who's actually had, who came to me basically for a knee problem, and I had a look at his leg. So this is classical. You can actually look in your practice. If you're not seeing them enough, you're not thinking much about it, but it happens all the time. So people will walk in and you ask them, look, have you ever been laid out for any reason whatsoever? And they'll always have an history of, I was in the hospital for 1 month, or I had a cast put on my leg or something, which gives rise to these kind of things, which is lipodermatosclerosis, which is basically deposition of iron in the subcutaneous tissue, which is related to the fact that your deep veins have blocked, your superficial veins have a venous hypertension from where the blood has gone into the subcutaneous tissue and has caused these kind of things. A venous ulcer, if you ask any vascular surgeon, will tell you it's one of the biggest disasters that you can have because they just do not heal. So this is what a 4-layer bandage and all, if you guys work with the vascular surgeon, you'll have a 4-layer bandage or something, needs to be done. They're very, very difficult, and you got to go and seal the perforators off. And it's always in this calf it's called the gaiter region where it normally happens. Here's what we know again. Every chemical prophylaxis carries a risk of hematoma and blood, hence the double-edged sword. So there is potentially a higher chance of other complication. Here's what we don't know. Till now, I was only talking about what we know. We understand higher rate, why higher rate. We understand the complications, why, what complications. What we don't know is, will a reduction in the DVT reduce the chance of pulmonary embolism? And does reduction of DVT actually reduce mortality? So if your end point of the game is, I want to reduce my deaths, then I don't have an answer for you, because there is no evidence in the literature which tells you that it actually makes a difference. Why don't I have an answer? Because if you need an answer for that, you need about 67,000 patients put into a trial to show whether it works or not, which is a huge undertaking if you ask me. So it is efficacious for reducing VT, but not maybe not efficacious in reducing the death rates and everything which are there. So what does a clever doctor do? A clever doctor is very intelligent. He's very observant. He keeps on watching his patients, sort of, morning, evening ward rounds. He identifies the high-risk patients, and he stratifies them and puts them into a, if you're a high risk, I'll give you this. If you're a low risk, I'll give you this. And these were the signs that he'll be looking after. What does an average person do? An average orthopedic surgeon like me makes a protocol and say, look, all the patients I'm going to give if I'm doing a procedure, I'll give it irrespective of what they do. I do what is called as a universal prophylaxis. What the naive oblivious surgeon does, I say naive with full respect to all my colleagues, it doesn't happen in my practice. I'm not going to treat them, or I'm just going to give them aspirin or something to that effect. So the problem is, when the patient goes away, you really don't know what's happening. A lot of them, and I say a lot, a small percentage of them will come with a sudden cardiac event or something which will be put down as a MI or something, and the patient will die and nobody will ever know because we don't do enough autopsies rarely. So this is the mortality figure which is denoted after arthroplasty. The figures are in front of you. Is this significant or not significant? Now that's a problem. Most arthroplasty people are senior people. Were they anyway going to die, or did I push them into it? I don't know the answer to that, but that's what we're looking at. So understand that these are the things which can happen irrespective of your PE, mortality and everything. This is different. So this is the kind of thing that people have. Is this significant, not significant? I'm going to leave it open for you guys to decide. But don't keep on going with the idea that, oh, DVT just happens, or a PE happens in the West, it doesn't happen, it's an industry-driven kind of thing. I don't think that's true. So there are lots of studies which I've looked at. Well, when I say lots of studies, no big studies. There's one from Wello, there's one good one from PGI which looked at autopsies of these people, which showed that actually the incidence of DVT is no less. It depends on how you look for it. So the way to look for it, you can do a venogram, or you can do an ultrasound. A venogram will show you a very, very high incidence. There is zero doubt about that, because it's the most sensitive thing. Ultrasound will actually show you much less. So there is no doubt about this. The underusage of VTE prophylaxis is in India. And how do you manage this? These are the ways that you can manage it. We all do the first three, I think. Well, we at least do early mobilization. I'm not aware of anybody who doesn't do early mobilization. Compression stocking is so simple. I mean, not doing it is. But the intermittent pneumatic IPD is like a go-to standard kind of stuff. There can be no reason why you would not put a calf pump on somebody. Really, there's no downside to it. It's not. You have one machine which will run. The problem is managing the chemical elements. So this is what you should be looking at. Essentially, it comes down to, are you preventing PE or not? So the ways to do it is, a lot of people like to give aspirin. There's nothing against aspirin at all. The only thing is it as efficacious in the arterial side as in the venous side? The answer, if you have a look at it, is slightly dubious, because it looks at what do you want to look for, and the literature will tell you. One very good trial which came out was the PEP trial. I think people familiar with that would know, multinational trial. But that was mainly looking at the incidence of DVTs happening in the non-arthroplasty patient. Arthroplasty became a small part of it. So it was not a very big, so that's the figures that were quoted. So one thing that came out was, actually the aspirin was no superior in the subgroup. This is subgroup analysis. So it's not a very high high level of evidence. But a PEP trial was a fairly decent trial when you look at the design of the trial. What they actually showed is there's no difference between aspirin and placebo, whichever element of DVT thing that you want to look at. And again, hematomas, placebos, etc. Not really. So maybe it is not that effective, but as I say, PEP trial has too many limitations to do this. And again, this is not one of my prepared slides. I'm so sorry about this. I shouldn't be advocating this, but it looks as if aspirin may not have. But if you want to use, at least use aspirin would be my indication to have a look at it. So the situation actually changed ever since the NOACs came into it. So then we started looking at, the first reason why we're not doing enough was because we had only injectable ones. But now we had oral ones, and the only thing is, were we actually making them better with oral? So this is the subgroup, and this is showing what the registries are doing. The registry is saying, I've actually dropped my aspirin usage, I've increased my NOAC usage. And look at normally what happens when you do that. So the temporal trends in thromboembolism actually drop down. So this is a subgroup analysis. When you actually dropping your aspirin, increasing your this thing, you show that your actual incidence of venous thromboembolism actually comes down. They were not looking for it. This is an analysis from within it. So I won't say sort of again the best evidence, but supporting this thing is slightly weak. Globally, you can see that the number of people using thromboprophylaxis is actually increasing. World over, everybody's sort of using more. So these are the common ones that are used, and the one that we really are looking much more nowadays, besides the initial period of Clexane. I think most people would agree the first 3 to 4 days you normally give Clexane. After that, what you normally give is a factor 10A inhibitor. So the commonly used ones are normally the rivaroxaban or the apixaban. Both of them are factor 10A. The advantage of one is one can be given on a once day, and the problem with the apixaban is, well, not the problem, but it needs to be given twice a day. So is it safe, is it effective or not? So that's what we need to take over. Dabigatran came in but not really used much anymore. I think most people would say that's not. So we're really sort of deciding if now we're coming to the commercial element. So excuse me for that as well. So between rivaroxaban and apixaban is the main study. So this was the direct factor 10A inhibitor. No effect on the thrombin, only binds to factor 10A. Is it effective? Is it not effective? So remember, these guys were up against a lot of evidence which had gathered on the use of enoxaparin, low molecular weight heparin. So there is 4 studies. The numbers for these studies are actually fairly amazing when you look at it. So there was the study on the hips, there was a study on knees as well, and they were competing. It was a randomized trial between enoxaparin and rivaroxaban, and actually if you look at the methodology of the study, is fairly good because it's a venographic study. So remember, doing venographs for over 4,000 patients, not the easiest of jobs, but again, big market, so I'm sure they could do it. And essentially what they showed was the pooled analysis showed that the total incidence of venous thromboembolism, remember, I can make a graph look big or tall depending on what I really want to show. So this is one of those examples. Not every value touches my significant level, but essentially, rivaroxaban shows a trend towards better efficacy than enoxaparin. Symptomatic VT, again, the same kind of thing. Rivaroxaban shows a better one. The pooled analysis for all-cause mortality showed that patients were dying less with rivaroxaban. This is an NEJM study. Less with rivaroxaban compared to enoxaparin. And PE and all-cause mortality, again, rivaroxaban scores better. Major bleeding risk, no real difference between the different things. So the bleeding risk doesn't seem to change much between all of them. The pooled analysis, again, showing no major complications at all. So this is, in a way, saying that, look, in a pooled analysis, there is no real added downside to giving rivaroxaban compared to enoxaparin. Is it a slightly higher downside? There is a slightly higher downside to other things. So it's something that you need to think about in your practice. You need to be aware of it. You need to keep looking at it. And you can have your own philosophy, but I would highly recommend you make some sort of a protocol in your hospital, in your institution, which you wish to follow. Just in case tomorrow there's a, Girish Tyagi is not here, right? No, he's not here. So just in case there's a legal issue tomorrow, you need to at least have something to address and say, this is what we do in our institution. So just a safety kind of a thing, but make sure that you at least do a physical prophylaxis. And I think the game has changed with the NOACs, but as far as the patient is compliant, the next question is how long and everything to give. That depends. The recommendation is about 34 weeks. But again, slightly more for hips rather than knees. But again, you should have something to show. Thank you so much, and really appreciate all of you staying back, and really appreciate the team which has put together the show. It was really being wonderful, and thank you so much all for being here on a Sunday.
Thank you very much, Gurinder. One interesting thing that we noticed a couple of days ago, we got a reference from the neurosurgery ward that the patient is not moving the toes. We went and saw the patient had a compartment syndrome of the leg, and we just examined the intermittent compression apparatus. It was not actually intermittent. It was giving a continuous compression. So moral of the story is, devices are good, but you must physically check whether the compression is actually intermittent. The patient had a nerve palsy and a compartment syndrome. We had to refer him to our trauma guys for a fasciotomy and all that stuff. Thank you so much.
If I may be allowed to ask one question. We are having a very common scenario. You have done a bilateral knee, and after third, fourth, you are giving prophylaxis, DVD prophylaxis, and third, fourth day, you get a call that patient has a dip in the saturation, right? You take opinion. The commonest answer will be, so we need echo, 1, 2, we need D-dimer, 3, we need to do a ultrasound Doppler, and 4th, we need a CTPA. So how you manage it? So do you get all these done, or how you take it from there? Because we are suspecting PE, correct? I want to ask.
Gurinder,
I
do you
think,
want to answer that?
Sure. Okay. So this is a fairly common kind of a scenario. So understand one thing: the risk of PE doesn't really go down to zero at all with any of this thing. So what I would do is, you see, they're very good indicators if you're looking for that. One is you check your saturation. The simple thing first. So do an ECG. ECG will show a P pulmonale or a right side stress. The second thing is do a saturation. You'll see a drop in the oxygen concentration. So I would do this. I would supplement it, and I would wait. The next thing I would do, if nothing is improving, I would definitely do an echo, and I would do my cardiac enzymes. I won't do a CTPA.
So what I have seen is that it doesn't make a difference with the CTPA. So I start them on double dose of a Clexane straight away, because you are covered, even if, because CTPA may happen same day, next day, or whatever. And if patient is improving, we do not do anything. We don't document anything. But otherwise, even if CTPA will show, you have already started the treatment, because treatment is not going to change even if it is a PE. You can't go in and take a clot out from the lung. So you better start the double dose.
One thing I would like to ask everyone, how many of you are using drains for knee arthroplasty? Just a show of hands, please. Very few of them. Gurinder, would you have any issues not using a drain when you are, do you use a drain or not otherwise? And you use injectable low molecular weights or oral? Inject. Vijay, do you have any issues with not using drain when you?
No, I routinely don't use drains at all, except revisions. Revisions I use drain, and I've had no issues.
So use what kind of DVT? Chemical prophylaxis?
Yeah, so I do selective chemical prophylaxis, not all patients, right? So depending on high risk patients, so those definitely get it, and they get low molecular weight heparin.
Do you feel that patients coming back for reoperation with a knee hematoma is a significant issue in your setup?
No, I have never drained a hematoma as yet, never.
With injectable low molecular weights?
Or anything, yeah.
Right.
I think one comment I wanted to make regarding Dr. Hemant's question, actually whenever there's a saturation drop, the first thing that the physicians want is basically a D-dimer and an ultrasoundologist. The thing is that D-dimer is, what is D-dimer? It's a byproduct of actually fibrin degradation. So
D-dimer will always rise after any given surgery.
Absolutely. It will be always high after trauma. So actually as soon as D-dimer is done, they start making a sound that this is DVT. Secondly, as Dr. Gurinder himself said, a lot of patients, almost 27% of patients, if you get a third day, fourth day, a routine, normal, in unsymptomatic patient, you get an ultrasound, you will actually detect an embolus, a DVT, a thrombus there. So these don't help us. And angiography, what it does is it documents. Although our treatment does not change, but what it makes is actually documents. Because at the end of the day, it is a fight between you and the physician, what is to be done. And if it goes to the court, who's going to take liability? So it is better to have a documentation. But please don't get waylaid by the D-dimer level as well as the ultrasound. That does not guide treatment at all.
Question to Gurinder. I'm sorry I didn't hear your whole talk, but what are your views on aspirin versus low molecular weight heparin? And do you think aspirin would cover, is good for DVT prophylaxis?
At the evidence that it works in venous thrombosis is rather on the low side. There are some pooled analysis. In fact, the ACCP still says that you can still use aspirin as a prophylactic agent. We personally have not sort of used it, but the majority of the evidence in the pooled analysis is not
Gurinder, sorry to interrupt. I think the American Academy of Orthopedic Surgeon guidelines,
so this is
it clearly states that aspirin is equally effective with a low risk of bleeding complications. And when you talk about PE, there is nothing that will actually reduce the incidence of PE.
So the thing is,
PE is basically because of surgical trauma, mostly, not because of stasis. DVT is because of stasis.
So what I wanted to
Vijay,
come
I'll
to
just
this
stop you
point,
there.
that you should definitely use aspirin if you're not using
Yes.
low mercury heparin.
See, the American
So,
Academy is
yeah.
divided now between the physicians and the orthopedic surgeons, and we are more concerned with the orthopedic guidelines. And the orthopedic guidelines now clearly say aspirin works. And we, for all practical purposes, why are we discussing it is for the medical legal aspects as well. And giving something is better than not giving. And so if you're looking at an aspirin, why not an aspirin? So we're better, but the goal is early mobilization.
Early mobilization.
So the most important take-home message should be
and
early
mechanical
mobilization.
prophylaxis.
So whatever you do, whether it's a trauma surgeon also, he wants to early mobilize. So early mobilizations, then of course use some mechanical. The Gurinder's talk would be something mechanical, risk stratification, and in that you look for mechanical pumps, stockings, early mobilizations, and of course, when the patient is in the hospital, it's a good idea to give injectables, which you can, and at home, you start risk stratification. And if you find that this is a patient who can have PE or has had some episode in the past, has some COPD issues, is obese,
Only subset.
then
Yes,
in those
only subset
patients,
of
you can use anything which will prevent a DVT and a PE, which is, of course, there.
Yeah, yeah.
And
Another
one
question
last
to-
thing,
Yeah,
sorry.
another question to Gurinder. So if you're using low mercury heparin, how long do you use it for? You use it for 4 weeks, 6 weeks, as has been recommended?
While the patient is in the hospital, we use it. After that, everybody
So
goes
I
home
think you would be,
on
you are doing enhanced recovery.
Everybody goes home. Everybody goes home on a NOAC.
Yes.
So the only thing is the NOACs, normally the recommendation would have been about 30 odd days. We're doing a 2-week NOAC, which is, I understand.
And the
is not-
recommendation is more for the hips than for the knees. You have to give, in a hip patient, you have to extend it more.
Yeah.
Knees, you can give it at for 14 days also, that's sufficient
Knees,
enough.
2 weeks is
but
sufficient.
2 weeks for knees
Yeah.
and 6 weeks for the hips is what is recommended by the American Academy, and we should probably try to stick to that.
And one last thing, use of technology-based assistance in TKAs significantly reduces the incidence of PE. This has been documented in very, very large studies. So anything that helps you eliminate the use of intramedullary rods for alignment-based things, whether it is navigation, robotics. So that is a great, great help.
Okay?
Yeah.
So, first I'll ask Vivek, you're here. So Vivek, if you can just give a memento to Himanshu. He's the only one left. You all have taken it. Second, Gurinder was very surprised. We took this session for the youngsters. I added a session specifically when we sat down to make the program. We will have interesting case presentations and we'll give the opportunity to the youngsters to come up and present. 8 cases, we'll try to select 4 best, and of the 4 best, we'll give them rotating fellowships at 4 different centers around Delhi. And imagine we just got only 2. The youngsters were not even ready to present cases on the stage. When in our younger times, we used to fight to get a case podium presentation. I don't know why, what has happened. But next time we'll just float it today itself, and next time definitely it is already there. Now we have these 2 boys who I want to present along with. We have 4 more cases from some fellows who just have come up. So probably I'll just ask, who is the first one? Pratik? Yogesh? Durgesh. So we'll have Durgesh to come up and present his case. Dr. Durgesh. And I'll ask Gurinder and Vivek if you can just come up and help us.
Should I start? There will be 2 cases, huh?
Please start, please start.
Thank you, sir. Thank you for providing the opportunity to speak on this podium. Here I'm presenting a case of a 61-year-old female who is
diabetic and she has a history of fall at home. The very first surgery what we think of is the bipolar hip replacement, what the index surgeon did. Everything was fine, but after 1 month she started noticing the discharge from the wound, and serial dressing was done, antibiotic was started, culture was taken, ESR CRP was high, what we are listening since morning, and this is 2 month post-op and this is a 7 month post-op X-ray. What happened on the 7 month, why she came after 7 months, in spite of dressing and discharge, everything was there, is this. She again had a fall and she was having a fracture of distal femur, supracondylar fracture of femur. Then again it was planned. In spite of the discharge was there from the proximal femur, the distal end femur was fixed. This is a 2 month post-op X-ray. And after 5 months, still cortex were, X-ray was showing that it's getting united, but still not, full union was not achieved. And the proximal femur discharge was still there, discharge was there, sinus was there, ESR CRP was high, culture showed a streptococcus. And then appropriate antibiotic again started. Then this patient came to us and we planned for the revision surgery. In the revision, we put the antibiotic spacer and we gave the antibiotic for 6 weeks. On subsequent follow-up, she actually, again, we don't know, she was giving mixed history whether she fell down or not, and she was walking with the help of walker. Obviously, we told her to nil weight bearing walk, but still she broke the spacer. And then it was around some 6 weeks post-op, so we planned again for the revision, and this time we again went for the bipolar prosthesis, not the total hip replacement, because the demand of the patient was too less. She this is the best we could do for this patient. So thank you for the patient listening. Please questions.
Why did you not choose to, along with the plate, remove the femoral implant, do a debridement and put a spacer in the same sitting?
Sir, till the plate, it was operated by some other surgeon, and then this patient came to us.
Okay, the patient came to you after getting the plating done?
After getting the plating done. And then still the discharge was coming, they were not happy, they were not satisfied, so they came to us, and then we operated this patient for the, we started on the antibiotic. Plan was to operate this patient in the very first we met her, but then we saw that distal femur plate was not, distal femur fracture was not united, so we took around some 1.5 months to wait, and then we planned for the spacer and all.
Was she walking at that time when she presented to you?
No, sir, she was not walking.
She was not walking.
She was not walking.
See, one comment I could actually, if I could make, is that we've not helped her actually by putting a spacer. We actually could do a girdle stone,
eradicate the
put some cement into the acetabulum and the femur and leave it like a girdle stone. That also works, and that actually makes these patients pain-free. Why I'm talking about this is the spacers in hip are a double-edged sword, because your chances of you succeeding become very high if you can give a very high interval where actually the patient is off antibiotics. Once we put these kind of spacers, there's always a challenge. Patient has some pain, he cannot wait, and you have to have that time between when you stopped all antibiotics and you're waiting for if the infection is coming back or not. In between the spacer breaks, and this patient does not walk. So what Dr. Vijay Jain, I don't think he's not there now. What a lot of people now do is that they will do a small loose cemented THR in which they actually make the patient weight bear and walk. Okay. What happens with that is that you can give them a long period in which the patients are off antibiotic and the patient are ambulant also. Yeah. And it saves the acetabulum.
Some of them will not come back to you for another revision.
Yeah, absolutely. Some of them does not. They don't come back. They're scared of surgery and they're happy.
Yeah, yeah, listen.
Even in a case report, unless you have a take-home point, the case report is of not much use. So your last slide has to be
take-home message.
Yeah, a take-home message. What is your take-home message from this?
Take-home message is in these kind of cases we have to always stick to the principles. Revision in these kind of cases, always the culture of the exact debridement of the surgical site, and then put the spacer, wait for the wound to be silent, and then antibiotics, proper antibiotic course, and then we have to plan for the proper planning of the surgery is the important thing.
Vijay, any thoughts or any criticisms here?
Please, sir. Yes, sir.
Sooner or later, patient is going to have pain whenever she starts walking.
So we should always go for total.
Always, always. That's not a native acetabulum there. Right? Bipolar is good for very elderly people, when they have a neck femur fracture, and the acetabulum is pretty all right. So, but this patient, you have done a spacer.
Already we have put.
Patient is weight bearing on that spacer, the acetabulum is totally gone. So you should have gone and done a full total hip replacement. And if you're worried about dislocation, do a dual mobility. And you said the patient is 62 years old or something.
Yeah, she is 62.
62, 66 is quite young in these days. It's not like, I don't know the other things, what comorbidity is there. But the message should be a revision for all of this, cannot be a unipolar revision. It has to be on both sides, total hip replacement.
Yeah, can I invite the next presenter? Is there anyone else?
Thank you. Thank you, sir.
Yeah, thank you. Thank you very much.
The next one we have is Dr. Prateek. Come.
Hello and good afternoon, everyone. It's a great pleasure that all of you have given me an opportunity to present my case on this podium. Since I am very early in my learning curve, so I have decided to present a case for a normal TKR. It's for the osteoarthritic knee that we have done the total knee replacement. So I have to start with the basic introduction for the osteoarthritis, which we already know, that it's basically a degeneration in the articular cartilage. And some basic, out of all the indications in the TKR, mostly the osteoarthritis is the most common one. We have these different categories of TKR processes that are available with us. Mainly they can be categorized under semi-constrained or unconstrained.
Can you move straight away to the case, please?
Yes, sir.
Yeah.
That's the approaches. And we have done a 68-year-old male patient, came to our OPD with complaints of pain and swelling or bilateral knees with severe varus deformity in bilateral knees since 8 years. And on examination, the swelling, medial joint line tenderness was present. A range of motion was 10 to 110 degree. Crepitus and varus deformity was there, but there was no sign of instability. This was the preoperative X-ray. These are all the basic surgical steps that we have gone through. And that is, I think, that's a post-op video that's showing the tracking. After placing the implant, that's the final post-op X-ray that we got. Rest is about the rehabilitation. The patient was being straight away put to walking on the day 1 only with appropriate IV antibiotics and low molecular weight heparin and everything being started for DVT. And this is the, I think that's the video. This is the post-op day 1 that the patient was being allowed to walk. And that's the day 3, the patient is allowed to do the stairs and everything. It's a part of rehabilitation. I just want to know about these, through this presentation is what I have learned through the TKR is staged knee replacement is a better one than doing a bilateral knee on a single sitting, because it always reduces the chances of blood loss during the surgery, and therefore need for blood transfusion and everything. Better pain control is always there, and a better rehabilitation is there. Always, one thing is, another thing is a judicious use of tourniquet, that since we are in early learning curve, we don't have, we are a bit of time constraints, so we just inflate the tourniquet just before the cuts only, so that unnecessary tourniquet time can be reduced. And when we are using this posterior referencing system, always go for the higher side, that is to prevent the notching and everything, and watertight closure is to be done. And a good pain control in the post-op period is the most and utmost important in achieving a better rehabilitation.
Thank you. Thank you very much. Thank you.
in this patient, what exactly was your thought process when you went? You told there was a 20-degree flexion deformity.
Yes, sir.
So did you go with the thought process and how you're going to manage that flexion deformity on table?
With the
Well, I don't think the X-rays did not show that kind
show
of a
that
flexion
much. It did not show.
No,
The clinic, we agree. We are not countering that. We agree. So what exactly were your plans? Because there was no osteophyte and anything. So what did you think on table?
Just the posterior capsule release on the femur was the plan.
Did it correct under anesthesia?
Sorry?
Did the deformity correct under anesthesia?
Just a bit, sir. 5 to 10 degrees was corrected, but rest is after posterior capsule release only it came back to straight 0 degree.
Gurinder, anything?
What was the, you said post-op pain relief. Did you do anything different? What is the philosophy of pain relief?
So we just, first of all, it's the epidural catheter that was being put, and another is the usual painkillers. So nothing much is to be added, but rest is depends upon the patient control, and ice pack was also being added to give a local pain relief, and nothing specific, sir, which was being given.
I'll have one comment to make about the no tourniquet thing. Actually, when you're new in your career, you'll get the junior most of staff with you, and you're also getting time. So it is better to have a tourniquet from start, so that you have a good, clean, bloodless field. Because to get a low tourniquet, you need to have a good anesthetist who will give you a low hypotensive anesthesia. Not me.
I think that's Diwali.
So I think it is always a good idea to go with actually a good tourniquet and good pressure. And as your career proceeds, you go for a no tourniquet.
So the idea was ki, with tourniquet time, it's going to increase because in my learning curve, I'll take a bit more. So I don't want to increase unnecessary tourniquet time. So I am achieving hemostasis just after
say more on wiping
Ramnik, you have any comments to make? On both the cases,
Total hip should have been the choice. Or if you're going ahead for a revision, then no questions, it has to be a total hip. And of course, in between, I don't use those spacers. Since 2012, cemented stems, cemented cups, loosely, poorly cemented. The patient can walk from day one. They work as spacers. And whenever you need to go ahead, you just take them out. And I can tell you there are many patients who have not come back. They're still walking and they come and say hello.
Yeah,
to
they
us.
don't.
So it's like a single stage revision also. You can say poorly done, cemented THR. So that is the take home message is do something which is more acceptable if it is you as a patient. You're a parent who's getting a surgery done. And the number 2 for you is again, if you need to learn, you need to avoid blood. You have to be not struggling with those small things around you. Tourniquet, retractors, assistants, and of course, as you said, if you're the junior most, your cases will always be the last, and the anesthetist will never be well trained enough with you. They would also be juniors
But
like
then
you.
there is a downside to it. When you are learning, you are spending more time under tourniquet. I believe spending more than 40-45 minutes on tourniquet is not a very good idea.
Finish your surgery and then remove your tourniquet and then do all
So
other
deflate the tourniquet as soon as your implantation is done. And there's no need to wait for the closure to deflate the tourniquet. Yeah. So that will reduce at least good 10-15 minutes of you. And then you can see the bleeders also, you can coagulate whatever is coming your way. So at least you can get another 10-15 minutes breather. Yeah.
If your surgery is getting late, you can deflate later on.
And in case you are stuck in between, you can deflate.
In between. Give
in
it a little
between.
time.
Wait for another 10-15 minutes and then reinflate.
Reinflate.
Yeah. Thank you very much for being here.
We just have one more.
Till the last
Vivek,
session.
We are about to finish. We have just a couple of fellows, they presented their,
Oh, sure,
they
sure.
made their cases. They won't take time, that is Dhruv, Dr. Dhruv. He is a fellow.
आपको felicitate करना है, चलो.
Good afternoon, everyone. I am Dr. Dhruv, and I am presenting my case on a stiff knee. The case details. Our patient was a 67-year-old female who had a history of a trivial trauma past 10 years back and had been having difficulty in walking in bilateral knees since the past 10 years. She doesn't have any comorbidities. Pre-op examination, the right knee was fixed in 15 degree of flexion. Left range of motion was 10 to 80, and active ankle toe movements were present. Right varus was 10, and left was 3.
I just want to stop in between. Just one comment.
Yes, sir.
Actually, you would have seen the main presentation, how everybody made the presentation. See, now you're a new guy, you have to present lifelong. See, what happens is that when you're given all the information in the first slide, now we've actually forgotten what has happened. So if all this come together, then we're more interested and we get the idea.
This is
So how old is she now?
Sorry, sir? 67 years
She's
old.
67, yes.
She doesn't have any comorbidities. She had a history of tribal trauma 10 years back. And since then, her range of motion, she's been decreasing and having difficulty in walking. Subsequently, she came to us with having her right knee fixed in 10 to 15 degree of flexion, and her left knee had a range of motion around 10 to 80 degree. Right knee had varus of 10 degree, and the left had a varus of around 3 degrees, sir. So these are the pre-op images. We had gotten her X-rays done, the AP and the lateral, and a CT scanogram, and also a pelvis with both hips, so that we could see if there was any deformity in her hips or not. So these are the post-op X-rays. The approach we used was a midline approach without a tourniquet, and we gave a large incision. We cleared out the lateral and the medial gutters. We gave a medial parapatellar approach. Then firstly, we cut the proximal tibia, made way for the distal femoral jig, then cut the distal femur, and after that, we put in our intramedullary guide. We gave the anterior cut and the chamfers. We gained more flexion, and then sequentially we removed the osteophytes, and then finally the posterior capsule to balance the flexion and the extension gap. And so, sir, the take-home message was that what I learned from this case was that we should be patient in such a case and do it without a tourniquet, do all the releases, balance the flexion and the extension gaps, and also the rehab should begin the next day. We started the range of motion the very next day.
How did you take the tibial cut? You did it in about 30, the range of movement is only about 45 degrees, 50 degrees, right?
Yes, sir.
How did you manage to take the tibial cut without at least getting 90 degrees?
So firstly, we took the proximal tibial cut. Then after that...
In extension?
In extension.
In extension.
Then we put the jig inside. Then we took the distal cuts. Then after that, we took the chamfer and the anterior cuts. Then in the end, we balanced...
Sorry, you took the proximal tibial cut in extended knee?
So in that, after giving the anesthesia, in the flexion, the movement increased a bit.
So what we're saying is your knee was from there, it was going to about there.
Yes, sir.
You were not reaching there, am I right? You're
Yes,
not
sir.
reaching 90 degrees.
Yes, sir.
The problem that happens is when you put a tibial cut, you need something to, one, protect the neurovascular,
Yes,
and more flexion, more neurovascular. So you were not sort of, you were there kind of a stuff.
Yes, sir.
Somewhat difficult sometimes to take a tibial cut.
Yes, sir.
Any tricks on how to actually get the knee to at least be there for the tibial cut? Because it's actually, in my opinion, it's easier to get the femoral cut first, because you can do that in pretty much very easy kind of a position.
And I don't think in this given case it would have been a great deal to bring the knee to 90 degrees.
Sorry, I thought it was range of movement was very different. Maybe I read it wrong. Sorry, I apologize if I read it wrong.
We thought that the patient had a little range of movement was less in this patient.
This was 10 degrees
Yeah.
only. Range of movement was only 10 degrees.
So fibrous ankylosing kind of
knee.
knee.
Fibrous ankylosis, and come what may, it just didn't budge. So I'm the culprit, so I took it in extension. So I did I just use the jig as a primary cut, like you do in a fused knee. It's like a fibrous ankylosis, just took a first cut as a primary cut. From outside, placed that jig and did not cross the posterior boundary, and then used an osteotome after that.
Generally, with a good quadriceps release, lateral gutter clearance, translocation of the patella instead of everting the patella, it generally does. But yes, I agree, sometimes you may need a provisional cut. Well, but a more logical sequence, I'm sure people would disagree. What I normally do is a progressive level of commitment. Like if you take a distal femoral cut first, you are committing to only 50% of the extension space. You still have things to, then you extend the knee, you can see how much extension space I've already got by cutting the femur. You can have a spacer in your hand and you can make a mark on the tibia. Okay, I will not cut more than this tibia so that this spacer will go in. So now when you go to tibia, you can know this is the level of tibia, I should not cut more than this. And once you cut that tibia, now you have committed to half of the flexion space and rest of the extension space. Still, you have the rest of the femur to complete, and now you can flex the knee. You can see how much flexion space is already created by cutting the tibia. Your femur is already there. Now you want to equate your flexion and extension gaps. You can just put a spacer on the tibia and make a mark on the femur, and I will not cut more than this femur so that my flexion and extension gaps will be matched. And in between, in your mind, you have to keep some room for, how much space you will get after osteophyte removal of femur. That pre-calculation, preemptive calculation has to be there. And then if your femur size is in between sizes, you can either upsize or downsize so that your final 4-in-1 cutter will match that mark and you will not be mistaken. So that is the sequence of progressive commitment to spaces. If you directly cut the tibia, well, most people do that. You've already committed to most of the, to both flexion and extension spaces. Or if you complete the whole femur first, then you have not taken into account the flexion space that will be created by cutting the tibia. So you have no chances of upsizing and downsizing the femur. Ultimately, the goal is to marry femur to tibia, not an independent evaluation of femur and tibia.
But how would he take a distal femur without getting an intramedullary rod inside?
Sorry?
How would he take a distal femur without an intramedullary rod inside when he's got a knee in extension? I think what he's trying to say is that he could not flex the knee enough to gain to femur. So he's taken a sham tibial cut which was in position, so get the fibrous anchors out of the way.
Yeah, I'm giving a general.
Okay, I got it.
Yeah.
I got it.
General sequence.
See, but I think the take-home message from is that if you've got a fibrous ankylosing, it looks as though it will open out. It does not open out. Don't try to flex it forcibly. You'll break something. I think this is the message you wanted to give. Great execution.
Vivek sir, sir, like you said that you'll keep a spacer, put a mark in the distal femur, and then plan your 4-in-1 cutting zig and cut the femur. But how will you manage the soft tissue tension? Like
once you have cut the tibia, assuming your tibia proximal cut is correct, at that point of time you use distractors. Put the distractor in the available flexion space and distract it. Now you will have a fully tensioned collateral, and now you can assess how much femur I need to cut. Just put a mark, provisional mark, just put a spacer and you can put a mark with a cautery pen. So that will give you a gross idea. Okay, I am not going to cut more than this femur, otherwise I'll have to put a thicker poly and my flexion space will not match the extension space.
Okay.
Yes.
Okay.
Good evening, everyone. So I'll be presenting a case of a 67-year-old female. She doesn't have any comorbidities, who came with pain in both her knees and was diagnosed with bilateral knee arthritis. So we planned total knee replacement, and she was planned to be taken after 1 month. So after 1 month when she came, she was complaining of pain in her left leg, left shin, and she was unable to bear weight. So we got a knee, so we got a knee, first I'll just tell about the examination finding what we got. There was 25 degree of varus deformity, and the range of motion was 20 to 90 degree with 20 degrees of FFD, and there was tenderness present over the anteromedial aspect of the distal tibia. So we got a long leg X-ray of the patient. In the long leg X-ray, I'll just tell you, I don't know whether it is clear or not, there is a faint line over here. So we diagnosed it as a case of stress fracture. So like, why this case is important is usually we encounter stress fracture mainly in the proximal part of the tibia. But in this case, we got a patient who has got stress fracture in the distal part of the tibia. So in the operation, we planned like we put a distal tibial plate in the MIPO technique, and we put a, the TKR was done using augments and long stem. So this is the case. Thank you. Thank you.
You left some screws approximately left. You've made a provisional fixation. Did the TKR came back and put the screws?
First MIPO plate was put. We didn't put the proximal most screws. Only that the unicortical screw, it was put after the stem was put.
I think a well done procedure.
I think
yeah. Thank you.
So, may I ask panelists as a take-home message for everyone? You have a patient for bilateral knee replacement. When do you decide to do one? If everyone can give 3 points, when you decide one is better than 2?
So I think the question we are talking about is when would you really like to do a bilateral, when would you do it as a stage procedure?
When would you tell your patient, both your knees are bad, but I want to do one knee replacement and the reasons are X, Y, Z?
Okay, so is that okay?
So you're staging,
Okay.
you're staging. You don't do, it's a stage procedure, why?
Fair. So I guess my number one indication would for doing a stage kind of a procedure would be the patient's high comorbidities, whether it is a chronic renal failure, a chronic arterial disease, a chronic a poor cardiac history. That would be my number one indication. My number two indication would obviously be the patient's own wishes. The number 3 would be if the patient doesn't have any marked deformity or a LLD difference between the two sides, as if no significant FFDs or a significant varus deformities. So a poor candidate is one, the second is the patient's expectations, third is lack of any significant difference in the deformities or LLD.
I think anybody more than 70, I'd be actually skeptical. I'd evaluate again. More than 2 comorbidities, again, diabetes, hypertensive, or maybe a heart disease also, I would actually start counseling them, then we may do a stage procedure. Third is morbid obesity. These are the patients in which I would actually come. Fourth, in which in a lot of people will answer, you have a patient who's a little plus minus for surgery, who's not skeptical, who's skeptical, theek hoga, nahi hoga. In those patients also I say get one done, because the immediate post-operative after a unilateral TKR is way better than the immediate of a bilateral. If you have a half-hearted patient actually who's not, he's going to cry big time and actually dissuade other patients also. And sometimes they have a poor prognosis.
Few patients, I mean, apart from all the comorbidity things and obesity things, I think even in the presence of all good lab parameters, everything, I think very obese patients with a varus deformity, you know what happens is once you correct both the knees at the same time, the knees become straight. But they are used to keeping their hips abducted when they walk. So initial few days, if you observe, the patient walks with a wide base gait, especially the ones with severe deformity. Now with thin patients, they walk with wide base gait, they can quickly correct to a straight gait in a few days, because that's a dangerous gait to have, because it will continuously put more stress on the medial collaterals. In very obese patients, what happens is, once they try to straighten the knee, keep the limbs parallel, their inner thighs touch to each other. They are not used to this. They develop ulcers if they're not wearing long undergarments, and they tend to injure their medial collateral very often, especially with the wide base gait. So, particularly with very bulky thighs things, I am always, telling the patients I will do one knee, and after a couple of weeks I will do the other knee, and you have to make a conscious effort to keep both the legs parallel. While you walk, you have to wear long undergarments so that the inner thighs don't scratch each other. This is something, I mean, beyond the usual reasons to do unilateral.
Thank you. So the reason I said this was for all the young guys, there are guidelines and it has been taken in the court of law. Age more than 75, hemoglobin less than 11, if patient is on oxygen dependent pulmonary disease, history of deep vein thrombosis or pulmonary embolism, and there are BMI of more than 40, age more than 75. Hang on, patient has taken the doctor because there was some complication, that these guidelines are made by our Indian orthopedic doctors only. They are available, they are 11 to 12 points, and I'm forgetting few of them, but major ones are, and even in diabetes it is written, if HbA1c is more than 7.5, please do not do a TKR.
But where are they? Are they there? Because I know of guideline, I can tell you. So
I think
I'll tell you, there is a guideline.
there are no formal guidelines as of now.
No, there is a guideline in clinical orthopedics. It was around 7 or 8 years, and there's a whole chart there. And then they have mentioned ejection fraction, creatinine level, everything. Everything is there, but I don't think they are Indian guidelines. They are guidelines which have been published. There was a consensus meeting or something like that, and it's I think 7 or 8 years back, and it's in clinical orthopedics. They are published guidelines, but not. I don't know anything of the Indian thing.
There are no binding guidelines.
Yeah,
but then
they are only suggestions.
We when
don't
it
say
comes to court of law, someone can quote any paper from DAM.
No, but yeah, you're right.
I think what Dr. Hemant is trying to make out it, there is a consensus. There are things on which we have a consensus. That's what. They may not be termed the name guideline, but there is something called in which we have consensus.
In fact, the Indian Arthroplasty Association is going to come up with a plan to have formal guidelines for unilateral,
But again, I'll say
for
75
DVT
is too much. I
prophylaxis
think
and
70
all.
should be. I think if for Indian context, I think 70 is the age, cut-off age, not 75.
All our patients are above 70, by the way, when they come for knee replacement.
And those guidelines were made when, conventional TKRs were, and now with the advent of technology-based, when intramedullary canals are not being violated, less blood loss, I think the guidelines must change.
And one more thing I want
to
ask.
We were in Chandigarh and we were discussing in the Indian Arthroplasty that we want in the GBM, we thought that we would discuss, and so that Indian Arthroplasty Association can come up with some recommendation and guidelines that will help us. Amongst the Indian Arthroplasty and the surgeons also, they could not even come to that page where they can put it as a discussion matter, so it was not even taken up.
So if it...
So we are there.
No, and I just want to know, when you talk about stage TKR, so what is the time duration you give?
I think
weeks,
that's a
3
basic
months?
surgical principle that, the body is in a catabolic phase for the first 2 to 3 weeks, more so in the first 1 week after surgery. So if you have to space apart, minimum of 3 weeks to 4 weeks gap should be there to let the body recover hemodynamically and the body immunity to also come back. Within this frame, especially in the first 1 week after one major surgery, the patient is more vulnerable to hemodynamic complications, PE and infection.
And this catabolic stage starts immediately after the surgery?
Yes, it does. I mean, it's not just a knee surgery, it's after any major surgery. That happens.
After every trauma.
It's like a second hit.
Okay. Thank you so much. We come to the fag end. Thank you, members of the jury. So you've been of great help that you're sitting here. And as we said, we gave this final word of thanks, but I thought I'll call it Hasta la Vista, baby. So you're talking of technology, it started with Terminator. The Terminator series actually brought in technology. So that's part of it, how you say Hasta la Vista. So as all good things come to an end, It's been a very wonderful journey. So that's where he says, so probably this journey, this is the third Smart Conclave official. Although this was the fifth in the series that I did, and we probably want to take it further. So the fourth Smart Conclave, the only thing we will have to think about a date, which probably will release very soon, considering DOA has released its date on the 8th to 10th November 2024. Yes. It's already declared. So that is one. But before we end, I would say thank you to everyone, starting from the faculty, who was great enough, because I started pestering them at least 3 months before or 4 months before this time. And it has been a wonderful journey of 2 days, but this journey could not have started and could not have come to a conclusion if I did not have the help from the industry. And I must tell you, Gurinder, the industry was very helpful this time. The moment we started discussing 4 months back that we want to do this, we did a small meeting in our executive, in our coffee lounge in the hospital, and I think we just didn't have a problem at all. They all said, yes, we will do it. We got a major hiccup when the NMC guidelines came up, but we were lucky, God was there, and nothing happened. So here we are. So thank you to every person from the industry who actually came up, supported us, starting from, I would like to name. I was just told, don't take a name, but I will name, because they were kind enough. Stryker, Merrill, Depu, Synthesis. The Synthesis component of Depu, not the Depu Arthroplasty, by the way. In Cure Surgicals, Pharmed, Zimmer Biomed, Heldium, Sun Pharma, Areen, Ipca, Alchem Laboratories, Intas Pharma, Link, Oxygen, Smith & Nephew, BioRange, Torrent, Universal NutriScience, Avroan Pharma, Heliards, Biocomposites, Sigma Ortho, Ansel, Axel Ortho, Precedence MedTech, and Miraculous. So we had these 26 people who actually came up, and in some form or the other they were here, and they all need a loud applause from us. But this could not have actually, I could not have done it, because our work did not suffer even for a single day. We operated even on Friday, and we had a good OT list. But still we managed to come up because we had these people around who helped us. They were there at all stages of planning, right? And they were probably talking to all of you at one point or the other. Starting from Dr. Gaurav Singh Bhandari. I can have them on stage now if I start calling out their names. Gaurav Singh Bhandari, Dr. Nandan Mishra, Dr. Keshav Singh, Gurinder, Vikram, you can all actually come up also and just say hello, stay with them. Give Jada. हाँ हाँ बुला रहा हूँ समर्थ विजय हिमांशु now I'm calling them up. Please be with them. It will feel very good, because if you are there and you acknowledge the fact that they helped us. Dr. Abhinav Kumar, Dr. Tanuj, Dr. Dhruv are the fellows with us. These four were the consultants. Tanuj and Dhruv are the fellows with us. Dr. Supriyo, Dr. Nitin and Dr. Aditya. They are the senior residents. All of these boys decided amongst themselves when the faculty was coming into the airport. One of these boys was at the airport to receive them. Personally, they went to the airport to get the faculty, got them into their rooms and arranged for everything. And even when they wanted to check out, they made sure some of the faculty who was coming in and the Hemant, please. Some of the faculty who was, I will come in. When the faculty was coming in to the aircraft and going out, it was a very tough task because of the pressures at the airport. And Gaurav was very kind enough, because he used his contacts, and some of the faculty were actually taken from the aircraft, or they were taken back to the aircraft, right, because of his contacts. So they did not miss a flight. So, yes, you know who to contact next time, Vijay. And he's Dr. Nitin, as junior resident. So these are the doctors who were with us when they worked day in and out. I'll take a photograph with them first. me call on stage. Now I see him. I was looking for him. Dr. H.S. Madan. He's from Rohtak, New Medical College, and he actually helped us to spread the word around. So Harma, you can also be here. Now our physiotherapists who work day in and day out, Dr. Jitendra Tiwari, you all can stay. Jitendra Tiwari, Dr. Anil, Dr. Gaurav, Dr. Mansi Yadav, and Dr. Divya Kaushik. They are the team of physiotherapists who work with us. Then our OT staff and the support came up. The OTs, the surgeries went flawless because of these two guys. They just took everything in their stride. So, I don't want to miss a name, so I definitely want to open this. And Rakesh, Satish, Akash, Binsi, Ranju, Anup, Vijay, Yashpal, Sylvia, Durga, and Merlin. Then supporting staff from the OPD. First and foremost led Rosalie. Rosalie has been with me since, Vijay? Rosalie has been with me since 2005. So she actually is in and out, and she leads this team of my OPD, and she is there with me since 2005. Along with Rosalie, we have Pandeji. Pandeji is the senior most technician. Pandeji has been with me since 2007. All my dressings and all those plaster room, everything, he manages the show. He wasn't there yesterday, otherwise you would have seen the Nagin dance. So we missed the Nagin dance yesterday. Sandeep, Ashwini, Arun, Pooja, Vishal, Santosh, then we had Rehan, Sujal, Tabrez, Shailesh and Santosh Gupta. So, नीचे बैठ जाओ, इधर आ जाओ, साथ साथ. हाँ, देख, just sit down. And last, these two people think that I was not going to call them. So, they would have been waiting, उनका नाम ऊपर था, मैंने उनका नाम नहीं लिया. वो दो जने is Manish and Sonu, Dr. Sonu. So, these two boys, Dr. Sonu has been with me again as a physiotherapist in 2008. And anytime and everything, if I get stuck or somebody needs to reach me, they only know that they need to call Sonu. Sonu ko pata hoga ki kahan hai. And Manish has just joined the team 2 years back. But all of this that you see around is single-handedly managed by Manish. But I just had to tell Manish, I had to just tell Manish, idhar jana hai, udhar jana hai, and between Manish and Sonu, they would just be running around, finding the right contact, whom to contact, including those kit bags or including those mementos that you see. They just ran in as to get everything organized. So probably this team actually needs the biggest clap. And I would like to invite two people, and I'm sorry to all the industry guys, but I will have these two people on stage with them because these two boys actually helped us a lot in running around with them. Kishan and Pallav. Pallav has arranged all the surgeries inside the theatre and Kishan has managed everything outside. Both are from Striker. But they actually, I can tell you, they did not even think once that they're from Striker. They even helped out with the Merrill guys. They even helped out with the Smithis guys. Everywhere, wherever I was getting stuck, these boys were right there. So and between them, I just have to add, because I've just seen him, he's smiling there, my MPS. He hears everything day in and day out. Please, bhai sahab, yahan piche nahi reh sakte ho. So Pranoy is the MPS from Striker, but we are very close to 500 robotics and Pranay is very close to 400 of them. So he knows कब इसको डिस्टलाइज करना है, कब प्रॉक्सिमल एंड डिस्टल करना है. I just notice इसको ऊपर नीचे कर दे. पहले ही would say ऊपर नीचे क्या हो रहा है. Now he knows कि ऊपर नीचे कहाँ बात कर रहे हैं. So thank you team. I think I need to come and sit with them.